I'm Jenny Cole-Mossman, and I am a licensed independent mental health practitioner. Right now I work at the Center on Children, Families, and the Law as the Project Safe Start coordinator. So some of you have had contact with me if you've been in family drug courts. We coordinate a project that does infant mental health, child-parent psychotherapy for parents and their children 5 and younger in the family drug courts. I obviously do other things like this at the center, and when I was in private practice, I saw all children and adolescents. So we're going to talk about the whole spectrum today. You're probably going to see that some of our examples are on the younger end as we go through here. We are going to have an OJS example that we're going to talk about later on, so we didn't leave that out. We just thought it would be a little confusing to do two at once. So, and I'll let Alicia.
I'm Alicia Henderson. I'm from the, not really working, it's hard to tell. From the Lancaster County Attorney's Office, Chief of the Juvenile Division, been doing that for, I don't know, 8 years or something. And I got, as we say, roped into this by Jenny because apparently I don't know how to say no. And I thought it would be fun to do a presentation with Jenny as well. And so I'm going to try to keep my mouth shut, but sometimes we'll not be able to during her presentation. I'm supposed to be, you know, sort of the Vanna White sidekick, you know, to her, right? Okay, no, never mind. I am going to instead, at the very end, just talk about preparing a therapist for trial testimony, something which the lawyers in the room all could teach if they were standing up here, but you didn't say yes. I said yes, so I get to say it. So anyway, let's do it, Jenny.
Begin. So, and as we go through, if you have questions, we're okay taking questions. If they're legal questions, obviously, we'll direct them to Alicia, and if they're on trauma and mental health questions, we can direct those there. So, oh, my clicker's not working. And technology and I are not friends, so. I started with this quote by Eli Wiesel that I don't want my past to become anyone else's future. Because a lot of what we do in Safe Start, and I think a lot of what we do is try to prevent people from coming back into the system. We want to prevent their children from having children that are in the system, and we need to pay particular attention to trauma when we're doing that. So my intention for you today is not for you to memorize these 12 core concepts that we're going to talk about. It's for us to have some meaningful discussion so that when you leave here, your perspective on trauma has changed. Because it's not trauma-informed to, you know, tell your client, yes, your trauma is very complex. That's the #1 core concept. It's for you to understand, internalize, and be able to apply that information. So I'm just going to give you a little bit of background. So a nationally representative sample of children and adolescents were interviewed in 2011. And half had 2 or more types of victimization in 1 year. 8% experienced 7 or more types of victimization. And at the bottom, 1.4% of direct victims had 10 or more types. You're probably familiar with the people on your caseload. They probably had more than 1 type of trauma. And the most common thing that we think of when we think of trauma is PTSD, or post-traumatic stress disorder. We're not going to go over this in detail. I'm just going to set a few examples of things before we get started on the core concepts. But for someone to have trauma or for you to need to be trauma-informed does not necessarily mean that they have to have this diagnosis. So, it's diagnosed when there's exposure to a traumatic event. And that event is described as actual or threatened death, serious injury, or threat to the physical integrity or self or others. So it has a lot to do with your perception of what that means. And that differs amongst lots of people. So the person responds with fear, so they feel helplessness or horror. In children, this is going to look like disorganized or kind of agitated behavior. They re-experience the event through thoughts, dreams, triggers, physiological reactivity, so they're going to have a body response, and they avoid stimuli that remind them of the trauma. They're also going to show some symptoms of arousal that are persistent. Sleep problems, irritability, concentration, hypervigilance, which is, a constant scanning of the environment or an exaggerated startle response. And these things are going to occur over a duration. So they're going to occur over 1 month's time to get the actual diagnosis. And there's some qualifiers. If it's less than 3 months, you might see acute on a report. If it's more than 3 months, you might see chronic. Well, and the most important slide is the functioning. So you do not get a diagnosis of post-traumatic stress disorder unless it interferes with your functioning, like every other diagnosis. So if any of these things don't interfere with my work, or for kids with school, with my home life or my relationships, you may not necessarily get this diagnosis. And in kids, you might see a lot of times, instead of a PTSD diagnosis, an adjustment disorder. A lot of times clinicians are more comfortable with that diagnosis for kids. So it might say something like adjustment disorder with mixed disturbance of conduct and emotions. That's probably, I see people nodding, that's probably one that you see more commonly. But there are certain things that are risk and protective factors for developing PTSD. Exposure and reminders and pre-existing conditions are the risk factors. And protective factors are family support. And the reason that I put these in here is because if you want to think in terms of things that you're going to be looking at, visitation encompasses probably all of these things. So when we're talking about multiple exposures, if you're going to have family time every single time and the trauma occurred in that house, you're going to have multiple exposures. Reminders, if you have people that were present or things that were present, smells, tastes, things like that, they're going to be there. And then at the same time, you might have the very same people be a protective factor. So it's pretty complex. Another thing that increases the likelihood that you would see a diagnosis of PTSD would be multiple exposures to trauma. And what we saw before is that it's pretty rare for someone to have a single exposure to trauma. Even if you think in terms of, and we'll talk a little bit later about how complex it is, but someone that has a medical trauma or a car accident, there are multiple things that happen in that process that are going to be a traumatic event. And the incidence of exposure to trauma increase the risk for further victimization and in turn have a negative effect on well-being. So here's the interactive portion. Why do you think that would be? This is where you all have to talk for a minute. Anybody? Just take a guess. You probably know this from working on your cases. Why do you think that would be? I was a therapist for 10 years, so I can sit silently for long periods of time and not get uncomfortable.
There's a hand.
So, okay.
It works.
Their self-esteem is low, so they're not able to provide what would normally be a routine response or routine defense to the problem.
Right. I mean, that's some of it. I mean, there's no right answer for this. I'm not going to say that's wrong. There's multiple reasons, and we're going to talk through some of them as we go through, but if you've been a victim of a trauma, chances are you have some of those symptoms that we talked about before. You probably don't have great family support around certain things like that. Your arousal system, you're not as able to gauge danger and things, and we'll talk some more, but can you think of practical examples? Any of your cases?
I think kids just think that's the way things are sometimes.
Yeah.
That's just the way it is. And
That-
so if it happens again, well, that's the way it is.
Right. What do you think are the implications for this if you're working with child welfare families, that they are more likely to have a trauma after they've already had a trauma?
Well, for example, if you have a child that has been sexually abused and then they act out in a provocative manner, you know, it makes it that much more likely that somebody, you know, or I don't know if the word is precocious, whatever,
Right.
that they might be sexually assaulted again.
Right? So this makes your cases a lot more difficult and a lot more complex for multiple reasons. And we'll discuss a little bit of this more later. So that was kind of your warm-up, your background. So you all are supposed to be on board that trauma happens and it may not be diagnosed with as PTSD, but that it's there. What we're really going to discuss are core concepts, and this will include the symptoms of trauma for different ages. We're going to talk about trauma assessments, and I brought a trauma assessment. If we have time, we're going to practice using it. I know you all don't feel like that's your role, but it's a really simple assessment to use, and it gives you a lot of information about the kids that may be on your caseload. And we're going to talk about trauma treatments. And the research on this changes fairly quickly, so I'm going to give you a couple of references for places that you can look up things that you might hear that someone's involved in or things that are recommended. So this is my big caution, and I should know better because I was a therapist, but we are going to talk about things that are distressing. We're going to watch some videotape of some babies, and it's particularly distressing for people who have young children sometimes to watch these videotapes because the child does have very flat affect. I promise I'm going to show a happy tape at the end to kind of try and repair some of that, but we are going to be talking about trauma, and it does trigger people's memories. So if you get up and walk out, nobody will notice, or if you need to shift around. And I should say, yeah, except for you, you have to stay.
I'm sure I have been.
You're already traumatized from me roping you into this. And the confidentiality piece on the video, this is a case that is here, so you may recognize this mother. You may have seen her up at the courthouse. I do have permission to use her tape. Everyone who's at her family drug court knows who she is, but she's really happy that we're using her tapes for training. So we're going to discuss these core concepts. If you need to look back and want to look more, they're on the National Child Traumatic Stress Network, which is a great resource anyway. You can sign up for their bulletin, and they send you all kinds of handy things like handouts about how domestic violence affects children, and they have all kinds of resources there. So the concept that we're going to talk about first, I just learned how to animate my PowerPoint slides, so if there's nothing up there, you have to tell me because I didn't know how to do that before. Traumatic experiences are inherently complex. So they have different moments that they're made up of. There's sometimes the actual event, the things that occur after the event. And we're going to talk about these in terms of Sandra. So Sandra's 3 years old, and she witnesses her mother being brutally attacked and severely injured. And some of this is going to be particularly vague, so we can kind of fill in some of the blanks as we go along. But what do you think the traumatic moments are for Sandra during this attack? So basically what happens is some guy comes, knocks on the door. We're not going to say which guy it is yet, but he comes and knocks on the door. Sandra opens the door. He comes through the door, and he beats her mom badly enough that they have to call an ambulance. And she witnesses the whole thing. So what moments in that, if we broke it down, do you think? Just say it out loud.
Is there any blood?
Yeah. Blood.
There's no blood.
Yeah. The smell and the sight of blood.
Raised voices.
Raised voices.
Hearing her mom cry for help.
Mm-hmm.
Seeing her mom transported out of the home by ambulance.
Right.
You might want to repeat it so we can get her.
Seeing the transport out of there by an ambulance.
Mom's fear.
Mom's fear. What do you think mom's face looks like right now?
Afraid.
Yeah. There's probably screaming. Okay. What kinds of things do you think Sandra might be thinking?
It's her fault.
Yeah.
She opened the door. She's wondering who's going to take
We're going to get to that. Probably not in the moment, but we are going to get to that. I mean, like right now while he's beating her mom's face in.
her helplessness.
Helplessness. Yeah. And
Protect mom, but can't.
Might happen to her.
that's right. She might be in fear. So children have these subjective responses at these moments, and there are changes in feelings, thoughts, physiological responses, and concerns about safety. So when we're thinking about her developmental stage, she's 3 years old when this all happens. What might be different about this for Sandra than if a 15-year-old witnessed it? Who takes care of her? Who feeds her? Who, tucks her in at night? When you're 3 years old, you're completely and totally dependent upon your mother for survival, and she's just watched that person be almost killed. It's a whole new complexity to witnessing that violence. Then if you or I saw someone, we might be worried about our own safety, thinking the person might attack us, but we don't have to worry about, being able to feed ourselves afterwards or where we're going to sleep.
Well, she can't articulate that.
Right. That's exactly right. That was just on the feelings. She doesn't have the ability to say what she was feeling, likely. What do you think her physiological response was? I should have gone. Fear. What do you think? I'm so glad you're here. Shaking, crying. Her heart rate's probably increased. Her respiration is increased, right? Which is similar to when someone's in a fight or flight kind of reaction. So when she starts thinking about this later on, what do we think her reaction's probably going to be? Yeah. What do you think her physiological reaction is going to be later on? Probably pretty close to the same. So, complexity is impacted by the child's experience of the trauma. So what happened in the past, their developmental level, which we just talked about, the response to the trauma. So what occurs directly after the trauma might add to the complexity. What might happen after this that might add to the complexity?
Mom might have to stay in the hospital.
Yeah. What about immediately after, too?
There could be somebody that she doesn't even know that's taking her somewhere.
Right. Somebody's going to come pick Sandra up. And what are they going to do with her and mom? They're going to separate them almost immediately because mom's going to need medical attention. And when you're 3, how much do you think you understand about mom going into a separate room and you're being kept out here and the last thing you saw was mom bleeding? Okay. But she's witnessed all of this and then doesn't have any language to discuss it. And it's also going to be affected by whether or not there's multiple or recent additional traumas and who's the perpetrator. So who do we think the perpetrator is here? Who's most likely from your cases for this to be the perpetrator? A boyfriend?
Could be the husband or it could be the father.
Right. And why would that make it more complex?
He probably has a relationship with Sandra.
Yeah, he has a relationship with her of some sort. He may be the other person that's going to take care of her, so now she's got a fear of losing 2 adults. He may not you know, he obviously is not going to be there to pick her up if he's the one that's the perpetrator. When we do child-parent psychotherapy, which we'll watch later on, kids do play trauma narratives, and I used to have this little boy, and his mom committed suicide in front of him and left in an ambulance and went to the hospital, and he would play always with the trucks, and people would go to the hospital, and they always died in some horrible fashion along the way. I mean, they were run over, they were chased and eaten by dogs, these really horrible, violent things. And it always happened that they never came out of the hospital. And what we realized later on, because he didn't have the language to express it until he's going through this, is what do you think he thinks happens at the hospital? Something bad happens to you, because when he saw his mom the last time, she was alive, and she went on a gurney to the hospital, and when she went in there, she never came out. So foster mom has to have knee surgery, and she's going to go to the hospital. What do you think happened to his behaviors? Through the roof. So he's got this fight or flight response that we're talking about. He's agitated. He starts wetting the bed. He's hitting her. Why would he be hitting her? He's mad at her. Yeah, why would you voluntarily choose to go to this place where you're never going to come out of? So we talked through this already. So in addition to it being complex, trauma occurs within a broad context that includes the child's personal characteristics, life experiences, and current circumstances. So there's two different kinds of factors. There's intrinsic and extrinsic factors that are going to impact this, that we need to think about trauma through that lens. So the child's experience of trauma, their expectations regarding danger, protection, and safety. So when we're thinking about a lot of the kids that we're working with in the child welfare system, what do you think their expectation is regarding danger, protection, and safety? For kids who've had multiple traumas and have been probably separated from a caregiver, what do you think they think the world looks like? Yeah, it's not safe. That makes trauma a lot more complex. You know, if my kids have something traumatic happen, they believe that the world is a relatively safe place, and they can come back to that attachment that they have with me, and we can start to heal some of that fear that they have. If you don't have that, and you think that the world is already an unsafe place, what do you think the trauma does? It just cements that thinking that the world is a dangerous, scary place. And then the course of the post-trauma adjustment. So what's happening after trauma? Are they getting into services? Are people, you know, all of these things that we're going to think about, what we're going to do to make this more comfortable as they're working through this. So here's some of the things that we're going to be thinking about. Extrinsic factors are like the surrounding physical environment. Community and cultural environments. And then we're going to talk about some of the intrinsic factors like temperament, their exposure to trauma, and their history of psychopathology. So we'll talk about Sandra's case. So she's going to live in a housing project with her mother before this, and on a daily basis they hear sirens, police cars, ambulances, and gunshots. What do you think she thinks about the world around her? It's very dangerous. So, and she's always been a quiet and a timid child. She's slow to warm up, and she uses her mother as a base to kind of explore from. So what we know about Sandra is that she's got a pretty close, secure attachment to mom in this really dangerous world. So how do you think this helps us understand how she's going to react to her mom being beaten almost to death in front of her? Yeah, she did. She just lost her only safe place. And she's the one that opened the door, which we'll talk about a few minutes later. The third core concept is that traumatic events often generate secondary adversities, life changes, and distressing reminders. Except for you can't see it because I didn't press the button. This is probably where you all start to come in on this process, if you haven't been already. So secondary adversities may include family separations, relocations from a residence or school, financial hardships, ongoing treatment for injuries, and legal proceedings. How many of your clients have every single one of those? If you're thinking about the kids, they probably have every single one of those. They may stay at the same school. These things are sources of distress in the child's life. So moving to your aunt and uncle's house is not exciting, you know, it's scary. All of these things that are happening, being separated, they're not good changes. And sometimes we try to, you know, oh, you get to go stay with your aunt, and it's like a sleepover. It's not a sleepover. Kids know this isn't a sleepover. They're being removed. And they often remind the child of trauma and loss. Why would that be?
That's the reason it's different.
Yeah. And they're going to be reminded every time they go on family time, parenting time, that this is different. I'm going to a new, strange place. I've got someone sitting next to me that's watching everything we do, which is another change that probably creates some kind of distress. My mom's nervous all the time. She's really stressed. So we'll talk about Sandra. So Sandra's mom is unable to continue working and for a period of time, and she doesn't have any insurance. And the family was already in poverty, but they have even more financial hardships now. So in order to make up for these lost wages, her mother is working a double shift, for which Sandra has to accompany her mother because she can't afford a babysitter. So she's still in the home with mom at this point. And Sandra spends long hours relatively unattended, following her mother while she cleans or sleeping in a motel room. So what's the secondary adversities here? We've got financial hardships, right, that we had before. What other sources might be distress in her life and might impact her kind of functioning and ability to overcome the traumatic experience?
She doesn't have time to play.
She's not playing.
Probably
She's not in her safe home.
She's not in her home.
not sleeping.
She's not sleeping. She's not doing any normal kid things. And the fourth concept is that children exhibit a wide range of reactions to trauma and loss. So there's a lot of things that impact their reaction to trauma, and we've done some things to make that better. What used to happen when a child was sexually abused? What happened when they made a disclosure? Before the Child Advocacy Center existed.
They were interviewed by 8,000 people.
Right. They were interviewed by,
The line comes along and asks them more questions.
right. Okay. So we've gotten quite a bit smarter about that and the post-trauma reaction. So what happens to kids now when they disclose sexual abuse? They go to one location, they have one interview that's taped. What's that location look like? It looks like a house, right? There's friendly people there. It's not a police station. So those kind of changes are going to impact that. Whether or not they develop PTSD and whether or not they have anxiety or depression already is going to impact the course of their recovery.
Jenny, could I interrupt?
Yep. Please do. So I can.
I'm sitting here thinking about the first responders, and I know we have at least one police officer here, and obviously caseworkers who are out doing removals. And if you know the child has experienced trauma and you're there because you've got to do the removal of the child, do you, based on this information, I mean, it's going to be traumatic. You have any advice for those people who are the first responders on those situations?
I think we go back to some of the things that we talked about before, and some of the things that the Child Advocacy Center has done a really good job of. So what do we know this kid thinks the world is like? What does Sandra think the world is like when you're going out? She thinks it's unsafe. You're a stranger. She's really upset. She's crying. She's seen all of this blood. She doesn't have the capacity to say what she's seen. How could we make Sandra more comfortable? Get her blankie. That's hers. So that's really important. Right. And quiet. So probably, you know, her being around when they're taking her mom off and all these things, we're going to try and shelter her from some of what's going on there. Do we want to take her to 10 different places? No. So, what else?
As soon as you can, let her know if mom's okay.
That's good. Yeah, reassuring her that mom's okay, or that you're going to try to make mom okay, because we don't want to be making promises to kids that, you know, we aren't going to be able to keep.
Somebody said quiet. I couldn't hear them.
Yeah.
Slow down.
Slow down.
Because there's a lot of hurry, I think, that can occur in an acute situation. And I don't, you know, with a 3-year-old, maybe, I don't know, it depends on the age. But really, one of the things the research shows is telling kids what's going on.
Mm-hmm.
The unknown, for the most part, is scary for all of us. Is scarier than, you know, just walking through what's going to happen next.
Truthfully, what's going to happen
Well,
next? Yeah.
truthfully, but knowing something. Now, you know, with a 2-year-old, it's a little difficult. With a 5-year-old, you know, it's legit.
Yeah. Probably depends on her developmental stage. What about you as the first responder? What does your affect and your physiological arousal need to do when you get around Sandra?
You need to be calm.
You need to be calm.
Speak in a soothing voice and try not to run around in circles and scream.
And I think particularly when we're dealing with kids that are under 5, the way that they regulate their emotions is by their primary attachment figure. So when Sandra's mom is gone, if we are really upset and we are really tense, Sandra is going to be really upset and tense. No matter if you say all the right words and you take her to all the right places and you get her blanket and all of these things, if you're tense when you're talking to her, she is going to be tense. And you think about her world, she needs someone to take care of her. And if we as the adults are scrambling around doing a whole bunch of things and the environment's chaotic, she needs one person there that's calm and relaxed, that looks like they're in control of the situation, because she just lost the person that's supposed to take care of her. We're going to talk a little bit about some symptoms of trauma, and as I go through them, if you have kids this age, you're going to say that's kind of a normal, that's normally what kids do. But what I want you to think about is, as compared to their peers, these things are worse, or again, they impact their functioning. So the first one for kids age 0 to 2 would be that they act withdrawn. I'm going to show you a tape of a baby a little bit later with some flat affect. But this is where sometimes we run into trouble with infant mental health. Quiet babies are not good babies all the time. Babies should be vocalizing. They should be crying. They should be making noise. And a lot of times what we hear, and I'll show you on this tape, she doesn't fuss. She's just so good. She just lays in her crib all the time. So This is one of those. They demand attention through positive and negative behavior. Anybody who has a 2-year-old knows that this is pretty much your standard day. But this is above and beyond regular 2-year-old behavior. And if you don't know what that is, go find somebody's 2-year-old that you can watch, or their 4-year-old. I'm sure that someone who has this problem at their house would love for you to watch for a while. They demonstrate poor verbal skills. So, and I have it on there's an app that the EDN has that will give you the developmental stages and milestones that kids should be meeting. So if you're going out to meet with, a 2-year-old child, you can look on the app and see what they should be able to do. Why do you think that kids who've been traumatized have poor verbal skills? Yeah, you learn to speak by interacting and having someone stimulate and read to you and talk to you. They display excessive temper tantrums. Again, 2-year-olds do this. This is above and beyond what a normal 2-year-old would be, whether it's an intensity or duration or the number of times it happens. They exhibit aggressive and regressive behaviors. So if they've been able to do something, do a skill, and then they no longer can do it, that'd be a regressive behavior. They have nightmares and sleep difficulties. Again, little kids have sleep difficulties. But if there's a change, if a kid was sleeping through the night, if they, at 2, they may be sleeping in their own bed instead of a crib. If they start to be fearful at night, things like that. They may fear adults who remind them of the traumatic event. And this can be a little bit tricky because they're 2, they're not going to say, I don't want to go see my dad because he really scares me. What do you think they're going to do when they're 2? They're going to hide behind their family support worker's leg. They're going to be reluctant to go. They're going to do the things that 2-year-olds do, particularly, I got to get my bag. I needed Dora. I can't believe you didn't have Dora, so now I'm going to throw myself on the ground. And I'm going to, scream and cry. I can't believe you brought me something other than Dora. Okay. And again, some of this would be developmentally appropriate when we have a transition. But we need to be having our eyes open. Does this happen every single time we get ready to go here? Every single time I see this person, this behavior happens. Or does it happen, with a greater intensity? They may have poor appetite, low weight, or digestive problems. My kids are really picky eaters, so again, this would be a change in that kind of behavior, or what above and beyond would be normal for that development. Same with poor sleep habits. So those babies, unless they've got poor sleep habits, if they're withdrawn and they're kind of quiet and they're maybe not quite developmentally on target, but they're pretty young, so your doctor's probably saying things like, oh, they'll catch up, which we really should be not saying things like they'll catch up. We need to be screening them at that point. You aren't going to get phone calls about those good babies because they're not causing any problems. These are the 2-year-olds you're going to get phone calls about. They scream and cry excessively. They show irritability, sadness, anxiety, and they startle easily. So these are the kids that are going to get kicked out of daycare. These are the kids that nobody wants to watch. These are the kids that I literally had foster parents to say, I can't keep this baby. It's up all night long. Like, I just can't. I know babies wake up at night, but this is something. They're hard to soothe. So I'm going to set up the video, and then I'm going to want you to kind of, based upon what we've talked about, I want you to look for some of these symptoms. So we've got a mother and her baby who's about 12 months old. And I'm going to just go through, at 12 months, these are some of the things developmentally that we think she should be able to do. She should be able to crawl well, to pull herself up to standing, stand alone, walk holding onto furniture. She should be imitating adult interactions. She should respond more to adults than other infants. She should want her parent or caregiver in sight at all times. She should express fear towards strangers. She should be pointing to desired objects. We're going to want her to reference things. So she wants you to look at them, so she's going to point to them or she's going to hold them up. And she should be saying a few words, imitate animal sounds, pay attention to conversations, so she should look like she's listening. Clap her hands, and she should be interested in books. What do you notice about Mom right now that looks just a little bit different? Her proximity. She's too far away. Yeah, her proximity is not good.
She just heard you.
It's kind of hard to see the baby's face. I wonder.
Uh-oh. Uh-oh. Where did Mom go?
Mom did a really nice job imitating her vocalization there. Do any of you feel like they're having a very good time? Yeah. No, it's not. Where is Mom's face and baby's face? They're back to back. And what should babies, did we just say, prefer? She should prefer looking at Mom right now.
Oh, it does make noise. Yeah, the batteries must be.
What do you think she's really excited about right there?
Whoever's there.
Guess that person's not Mom. That's a stranger that she's probably met a couple times.
That's all the sound it makes.
This is about the time in the tape where everyone gets really uncomfortable. Would you like to be on this visit if you were Mom or baby? Yeah. Why do you think she's not moving on to another toy? She can't get off. That's exactly right. But Mom's not doing a great job of reading her cues and saying, baby wants to get off of this toy. She's really not enjoying this. Did she reach for her mom?
No, not quite
Yeah.
Here we go. He's so funny. He's too funny. He's too funny.
What just happened there? We call that caregiver rejection in our assessments. So mom tries to give her the affection. If you were a mom and you're trying that hard, how exhausting would your visits be? And there's no reciprocation from the baby, or very little. So imagine doing this for 4 hours. You'd be exhausted and depressed. So what were some of the symptoms we saw? We kind of went through them as we went, but how do you know she's got flat affect and she's withdrawn?
Her facial expression, what you could see of it really never changed. There wasn't great joy at playing. There wasn't, it was pretty much, she looked like she was enduring it.
Yeah.
Not laughing, not babbling.
She's not vocalizing hardly at all. We're going to watch some tape later on of her by herself, and you'll be surprised at what she looks like when she's by herself.
Well, one of the things that it seems to me is that the mother doesn't have any understanding of how to be a mother. And we were talking earlier about what kinds of things can exacerbate the trauma. The mother doesn't know, what color is this? Is this a circle? This is, goes around, or, just even talking to her, or things that she doesn't have any concept. And it seems that would really increase the trauma for the
Right.
child.
Even her holding the baby always back to back, or the proximity, is going to make it difficult for her to comfort that child. So we're going to watch more of her later on. This is a tape from one of our parent-child interaction assessments that we do for Safe Start. And this is a portion where they just do some free play. And this mom, that baby's exposed to some pretty serious domestic violence. And mom had a lot of difficulty at the beginning because she said, what does every parent say is going on when there is domestic violence with their kids? What's the baby doing?
Sleeping.
Sleeping, yeah. So, and then in this case, I read the police report and the baby's not sleeping. Although there was a great, NPR had some great research on, it doesn't matter if the baby's sleeping. The baby can still hear the angry voices. The baby's still aroused by it. So whether they're sleeping or not, we can put that to rest.
So with this video, then mom knew that she was being assessed for learning abilities. So chances are she was trying to.
Yes, mom is trying as hard as she can at this point. What they're instructed to do is play as you normally would. But when you know you're being videotaped and there's a therapist sitting across from you, it's not like you're going to get up and get your iPhone and grab a cup of coffee and put Dora on for the kid. You're going to try to do your best. So this is mom's best parenting. And I don't know if you guys, when you're watching it, but when I watch it, I'm pained by how hard she is trying. She really wants to. The problem is she has not done that before. So when she does that, the baby's not going to respond to her. That's what people always, when we videotape, they say, well, but the kid will respond because mom's trying extra hard. They don't, because they're not used to that. And the greatest is when we have a little bit older kids and they say things like, why are you doing that? What are you doing? They're puzzled by the parent's behavior, or the parent smiles at them and they kind of look at them like, okay, I guess I'll just go with it, So 3 to 6-year-olds, we're going to have more acting out in social situations. And again, if you have a 3 to 6-year-old, this is your daily life. But if you cannot take them anywhere for long periods of time, and this is a change, that could be a symptom. Again, acting withdrawn. And again, the attention through positive and negative behaviors. They're going to get a little bit more vocal at this point. And when we do Safe Start assessments, when Dr. Osowski used to show us all these training tapes, and when I started doing them, I thought, that's funny, the kids always swear in these tapes. And I thought, but just must be what it is. And then I started doing the assessments, and the kids about this age is when they start swearing. So you get a little picture into what the language might be like at home, because they're picking up language from their parents. Well, what do you think they hear? They might start to display excessive temper. You might see some kind of self-injurious behaviors, bangings of heads, things like that. They might be anxious, fearful, or avoidant. They're going to start to be going, hopefully, to some appropriate daycare or be around some peers, and they might not be very trusting and have some difficulty making friends. They might start to be verbally abusive. Now, again, if you have a 3 to 6-year-old, sometimes they're verbally abusive anyway because they say things like, you know, I hate you, mommy, you're not, you know, you're the worst mommy in the world, kinds of things. This is a little different. This would be emulating kind of the language and the things that they're hearing. Like Sandra, they're going to believe that they're to blame for the traumatic event. What do we know about kids this age? What do they think about why things happen? Yes, I am the center of the world and I make everything happen and everything should happen according to my plan. So when bad things happen as well, they're going to believe, because they have that magical thinking, that they can make things happen. You might see them start to develop some learning disabilities. You're going to see aggressive behaviors, sleep difficulties. They're not really great at locating pain, but you might start to hear stomach aches, headaches. Joint aches are pretty common too. Kids, my knee hurts, my leg hurts. Again, they might fear the adults who remind them of the traumatic event. They might fear being separated from a parent or a caregiver. They're going to have difficulties being focused and learning if they're in school or in preschool. Why would that be? They're not sleeping. And what did we talk about? What's their physiological state probably most of the time if they've just endured a trauma? They're hypervigilant, and things are triggering them all over in their environment. So if I'm trying to go to preschool and do things, and all of a sudden I hear a loud male voice, and I've been in the middle of a bunch of domestic altercations, what's going to happen to my concentration level? It's going to tank, right? Which makes sense because they're going into that fight or flight mode where they're going to have to figure out how to protect themselves. Poor sleep habits. They may start to imitate the abuse or the traumatic event. And what do you think happens when this happens at preschool and other places? You get shut down, right? The kids are, you know, doing some play and the preschool teacher comes over and says, oh, no, 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 you know, Bobby, we don't do that here. You know, the dolls do not lay on top of each other and do that. We do not do that, right? Or mom on a visit, you know, might say, we don't do that. They might lack some self-confidence. Show irritability, sadness, anxiety, poor skill development. They might startle easily. And they might start to see some other regressive behaviors that are a little bit easier, like wetting the bed, if they've already been toilet trained, wanting to sleep with a parent when they've already slept in their own bed. If you want a list of these, there's a checklist of them on this website. Is there anything you want to jump in on? This is like 3 long lists of symptoms, and they're really similar.
I was actually, now I was thinking about supervised visitation, and you know, there are no safety concerns during visits. How many times have we heard that? And I'm thinking there's Jeff Schmidt sitting over there, you know, and really how important the people who are doing the visitations would be to provide guardian ad litems, parents, attorneys, the county attorney with information about really the well-being of the child if they knew what kind of symptoms, things to look for, and you know, to really gauge, you know, how much face-to-face interaction was going on, other such things during visitation, so that we would have some information about that. And part of it is, you know, of course, you guys are always thinking it's evidence so I can get a termination, you know, out of the case, but it really is better used as evidence to show that the parent needs help learning how to address the issues, the trauma that the child has, and that the parent's the one who needs to work on those issues and learn how to actually parent this child. So yeah, we had no safety concerns is not helpful.
The other one I see a lot of times is the child, they're very bonded because they sat on their mom's lap the entire visit. And the kid is 4. Is that what 4-year-olds should do? No. So when you're reading those reports, if you looked at the EDN app or one of those developmental wheels and were able to say, I got to compare what a child should be doing at 4 compared to what's going on in this visit. Are they acting like a 2-year-old in these certain areas? Or are they doing things that are abnormal? When a child is 9 to 12 months and they go to end that visit, what do you think should be happening? There should be a lot of crying. There should be a lot of problems at separation when you're in focused attachment. That's going to be difficult for them. So,
How is the transition for trauma when there's a sibling involved? Like how much does that affect when there's an older sibling who wants to protect the younger sibling, or a younger sibling, siblings close to the same age? Because a lot of my cases there's at least two, and they're close in age.
well, and I think that goes to the complexity and having to look at the context. For the older child, they might have had fantasies about protecting the other child, or they might have been caregiving and doing some of those things. So I would think in terms of more the older child, but then you might be separating that child from, I've had cases where the siblings are separated and really the primary attachment figure is not mom or dad, it's the older sibling. And so they're now separated from what is the primary attachment figure for them. So 6 to 11 years old, you're going to be able to recognize these kind of symptoms a little bit better. Kids are a little bit more verbal. But nightmares and sleep disruptions, aggressions and difficulty with peer relationships in school. Again, if you have a child this age, it's not uncommon every once in a while for them to come home and be having peer issues. My daughter's in 2nd grade, and she told me the other day, because I am a therapist, that she needed to do more yoga because 2nd grade is stressful. And I didn't understand about how stressful it is because there's bullies and things that I don't know about. So that's pretty normal. I'm not going to say, oh my gosh, she's clearly been traumatized by something because she has one of these symptoms. This would be more serious. Difficulty with concentration and task completion in school. What's going to happen to this kid? He's going to fall behind. What is he going to be taking probably within the next 6 months? ADHD medication. And that is a huge problem for differential diagnosis, because if you do not know if a child has been traumatized as a therapist and you give me a symptom checklist, I'm going to tell you a lot of these things like aggression and concentration issues. I'm going, well, this kid clearly, has got some ADHD going on. What do you think happens to someone whose body is constantly in a state of vigilance when you give them stimulants? It's not good. And then guess what happens? Then we go back to the doctor and say, these stimulants aren't working. So then what happens? I got something to bring Timmy down at night. I'm going to give him this. Okay, and then pretty soon we're on 4 medications. So making sure, and we'll talk about some other things that you can do more clearly later on, that you're informing, everyone involved in this case that there may have been a traumatic event and how these kids are reacting, and you being the one in the room to say, he's not really impulsive. He's just, every time you, slam the door, he starts to get agitated. Or, when it gets loud in the classroom, he has trouble concentrating. They may show some withdrawal or emotional numbing. School avoidance or truancy, we're going to talk a little bit about more of an OJS example, but I always find this particularly sad because a lot of these kids have had a trauma and then they start getting in trouble. And what do they probably already think about what happened with the trauma? Whose fault is it? It's my fault. You know, if I hadn't opened the door, if I hadn't gone over to my friend's house to spend the night, if I hadn't told, none of this would be happening. Well, now I'm getting in trouble at school, and what's happening? You know, why can't you sit still? You know, you're always getting kicked out of school. So 12 to 18, we're going to see something more like along the lines of antisocial behavior, including school failure, impulsive or reckless behavior, substance abuse, running away. Again, can you see how really easily these kids could go from having a trauma to becoming what, you know, this is a delinquency kid. They might show symptoms of depression. In this age range, depression does not always look like sadness. A lot of times it looks like irritability. And it would be more extreme and irritable than normal teenagers, which, as you know, again, you're going to have some of. Anxiety, and you're going to see withdrawal. And again, when kids are 14 and 15, you're going to see some withdrawal anyway. They want to go up to their room when they get home. They want to be, you know, with their friends. They don't want to be around. But this would be above and beyond what was happening before, and it would be above and beyond compared to their peer groups. So just some symptoms in general that you might see across would be things like re-experiencing trauma. So flashbacks, which are, you know, them thinking they see, hear, smell the things that happened before. Nightmares, repeated play of the event. And don't, you know, as a therapist, we used to always wish that could happen in our office so we could address it, but it doesn't always happen that way. It happens at preschool. It happens at school. Avoidance of people, places, or things associated with the trauma. And avoidance discussing the trauma. What does that look like when you get therapy reports and say, this kid is totally non-compliant? They will not talk about anything. You think, well, A, the therapist isn't doing their job, right? Or, you know, what am I going to do with this kid? He doesn't want to get better. Numbing. So they might feel detached or estranged, kind of have a restricted range of emotions. This also includes not wanting to plan ahead for the future. And they may have some arousal. So they may be distracted, lacked concentration, irritability. They may have startle responses and trouble sleeping. I'm going to pull all these up here. These are some other kind of symptoms that just in general you might see. Whoops. We talked about anxiety and depression a little bit. Affect dysregulation. They're not able to calm themselves down. So when you and I start to get upset, we kind of are able to mediate that like this. Like their elevator goes from floor 1 to 20 in, 2 seconds. Dissociation, daydreaming, forgetfulness, personal changes or personality changes or emotional detachment. You might see some suicidal behavior, some self-harm behavior, regression, or impulsivity. There's a big difference between suicidal behavior and self-harm behavior too, which is more than the scope of what we're looking at today. But most kids who are self-harming are not attempting to die. They're self-harming in an attempt to relieve some kind of pressure and pain and their hopelessness. So they want some control. So we're going to go back to Sandra and talk about her symptoms. So Sandra's mom, she's pretty attuned to her, and she reports that she's not sleeping through the night and that she's waking up several times a night. She started wetting the bed. She used to play with other children at preschool, but now she's isolating herself at the corner, in the corner or in a playhouse. And Sandra becomes upset because she can't see when she can't see her mother, but she's easily comforted when her mother tries to do that. What does that tell us about Sandra's mom and her relationship? So, well, if she's easily comforted at the end. Oh, does it say she's not? Okay. So you read my slides better than I did. So she's not easily, so you're right, it tells us the bond is broken. But what if she is easily comforted and she's only seeing her mom twice a week? What are we doing there? Yeah, we're probably... She's got some symptoms of regression. Do you think that Sandra's mom, if she's involved in the system, is probably going to report all of these things to you? If you ask her and say, how is Sandra doing? What is she going to say? Great. She's great. I don't have any problems with her. And you might even be really trying to be trauma-informed and say things like, is she sleeping through the night? So, oh, sure, she's great. I'm going to check our time. The fifth core concept is about danger and safety are core concerns in the lives of traumatized children. So it magnifies concerns that they might already have about safety. And we talked a little bit about this earlier. You know, when you're dependent upon a caregiver, you need them to keep you safe, to keep you fed, to keep you clothed. They may start to have some inability to determine safety after a trauma. And this can be exacerbated by kids who live in dangerous family community environments. I think it was you, Barb, that was talking about this a little bit earlier. Maybe all they know is this continual cycle of conflict, particularly in domestic violence. If you live in a household where this happens every night or every week or every weekend, what do you probably think is normal and safe? What do you probably think is normal and safe?
That level of conflict, that level of
Right.
chaos.
Right. So if one of our kids, then we said, okay, you're going to spend the night over at Timmy's house where his parents are going to scream and yell at each other every night and his mom gets punched in the face, what would our kids probably do? They'd be saying, I got to get out of here. Like, this is unsafe. Like, things here are not safe. So they're still able to gauge that kind of danger and say, like, this is not okay. Like, this is not good for me to be in this environment. Kids that have been continually re-traumatized in that environment are not going to be able to do that. So we'll go back to Sandra a little bit. So her mom's really frustrated at bedtime, and she assures Sandra over and over they're safe. She's putting new locks on the doors, she's looking under the beds and closets, and Sandra's still persisting in this fear. And her mother knows, they both know, that all those noises are making them anxious. And so they both have an increased heart rate, faster respiratory patterns when they hear this sound. And Sandra's mother also notices that they both startle when someone knocks at the door. How do you think they're both feeling? Scared? How do you think Sandra's mom feels taking care of Sandra at this point?
She's not really able to.
Probably really helpless. You know, and we're going to talk about birth parents and trauma and the complexity of this, but she is pretty helpless. She's doing everything she can. She's already worn out. She's got her own trauma that she's dealing with. And at bedtime, neither one of them can sleep. Her physiological state is aroused at all times, and so is Sandra's. Do you think they have much fun together? They probably do not have a lot of enjoyable moments. And safety-wise, do you think either one of them has a very good gauge of what's safe and what's not safe? So what do you think Sandra's mom might do when she's feeling really helpless and really tired and just needing to be comforted? Drugs and alcohol. Get a boyfriend. And what kind of boyfriend do you think Sandra's mom is probably going to pick at this point? Because, yeah, like she's not able to, she's going to go and she's going to say, this guy looks great. You know, like I can't understand why my caseworker and you were all up in arms about this because, I mean, so, you know, he's got a little bit of a record. All of my friends and family do. He's changed. Yeah, he told me, yeah, he's all right. She's not going to be able to gauge that safety. And if you think about what she's coming from, again, we're all on the outside. We're all the little kid that would be spending the night saying, like, this is not normal. And she's looking at us saying, like, this is perfectly safe. I live this every day. I live around this person every day. I have no idea why you're all concerned. Traumatic experiences affect the family and the broad caregiving systems, and we've been kind of talking about these things interwoven. They disrupt interactions and attachments. Sandra's not going to be having a mom who is going to be able to sit down and read to her and pay attention to her and do all of the things that she needs to do to bond, because Sandra's mom has got a lot going on. She's got a lot going on because she's got to work 2 jobs and she's got financial problems. She's got a lot going on because she's got her own trauma. She might have medical things that are going on. She might look at Sandra every time and be reminded that Sandra opened the door. And what else might she feel when she looks at Sandra? Resentment, guilt, huge guilt. And we see this a lot in the family drug court. When parents get to a point where they come to clarity and realize what they have done in the presence of their children, they feel incredibly ashamed and guilty. And what do you think then they want to do? Relinquish, which is really common. Go use. Stop CPP every time, and Judge Heidemann tells them they can't. So we'll talk a little bit about repairing this. What about their reaction and their ability to meet the needs of their children? So when Sandra's up in the middle of the night for the 5th time crying about nightmares and her mom can't sleep, do you think that she's going to be real patient getting up? No.
What is CPP?
It's child-parent psychotherapy. I'm sorry. We're going to revisit that a little bit later on when we get to treatment. It's more a note for myself, but I don't know why I put it on my slide. So Sandra's mother's extremely fatigued. She's not sleeping well. She's got her own nightmares. She's taking care of Sandra. She's powerless. She can't soothe her when she's crying. She's feeling guilty. And she's told Sandra it's not her fault, but Sandra that doesn't seem to help. And Sandra's seeing her mom look worried and tired, and she wants her mom to notice her, so she cries a lot to get her mom to hold her. So what do you think mom sees that as? One more burden. I know we're all sufficiently depressed about Sandra's.
I'm getting more and more depressed.
I know.
I'm waiting for the treatment part.
I know.
Get in here.
If only there were
You're
7
only on
instead of
7.
12. I know. And I kept thinking when I was putting in this example, like I thought, well, I'll put something uplifting, and I thought that's really not very realistic. Like this doesn't get better, you know. And that's the point. I'm hoping that when you leave and you're able to see from someone's perspective that is stuck in this trauma, that it's not getting better unless someone is intervening at some point. You know, Sandra's mom is not going to get less tired at the end of your hearing. You know, she's not going to feel any less stressed. In fact, she might feel more stressed. So here's kind of a little bit of sunshine. There's protective and promotive factors that help with trauma. So protective factors are ones that buffer against the trauma, and promotive ones are ones that just generally enhance childhood adjustment. So we're thinking about things like high self-esteem and self-efficacy. If a kid has this to begin with and they have a trauma, it's probably going to be both a promotive and a protective factor. Coping skills. if someone has coping skills to begin with, they're probably much more likely to be able to endure a trauma. A positive attachment is a huge one. Why is that? Right. You started out, if you have a positive attachment with an understanding that the world is probably a safe place and I've got this secure person that's going to keep me safe. A strong social support network, reliable adult mentors, and supportive community environment. Here's my downer on this. How many of these things do you think that your clients usually have? Probably not a ton of them. So, but we'll just assume that something good's going to happen. And Sandra's mom's referred to a therapist after the attack by the social worker. And she's able to get Sandra to therapy once a week for the most part. And she's beginning to realize that her own trauma is starting to impact this parent-child relationship. And through this, they decide that they're going to put Sandra in a preschool program, and they make the teacher aware of the trauma. And she's making special efforts to ensure Sandra that she feels safe. Trauma and post-trauma adversities can strongly influence development. And this is something we should be particularly aware of with young children, that developmental competencies and reaching milestones can be impacted by trauma. So cognitive functioning, emotional regulation, their ability to control those feelings, interpersonal relationships, these are all things that can be impacted. And you may see regressions and disruptions, which is why a big part of our project and a big push that we've had is to make sure that these kids are getting these developmental screenings, the CAPTA, the Part C. How many of you see that or know what it is? If you just raise your hand. Not a ton, then. This is an educational assessment that they should be having. And if they qualify, they get a service coordinator and some services through early childhood. And again, we could do a whole nother training on that. So Carol could probably jump up and tell us about it. But you don't get the reports at all? About 50-50. Okay, we're working on it. So Sandra's preschool teacher, she's noticing that she's withdrawn from other students, and she's aware that she's begun wetting the bed. And she noted that her withdrawal is affecting her learning. So she's going to refer her on to make sure this developmental screening is done. It may not have gotten done because the parent is able to say that they don't want the screening to be done.
But Jenny, so many times what happens is they're told, oh yeah, she was removed from her mother at 2 years old because of domestic violence. They don't get the details.
Yeah, and I think that's where you can be really helpful if you know the details, making sure that that evaluator is aware of the trauma information and what that child looks like across different areas of development. We've had some trouble with this even with our own therapists. So if your kid is removed from you and I start asking you questions about their development and I say, do you have any developmental concerns? What do they say? No. I mean, first of all, they're probably thinking, what is a developmental concern? And I'll just say no because I don't want to do one more thing. We've tried to have them start coming to pre-hearing conferences. So you might see a person from the Early Development Network up there when you're in a pre-hearing conference. So use them and ask them about, this kid is 3, what should we be seeing? What should be going on here? And help them get engaged with the parent so that they can voluntarily provide that service if necessary. So developmental neurobiology underlies the child's reaction to traumatic experiences. What we're dealing with is an evolving neurobiology in children. Their brain is not completely formed. And especially with young children like Sandra, we're dealing with a great period where there's a lot of plasticity in her brain development. And she's developing, this danger apparatus, this gut that you all probably have, that you know and think this is not a very good situation. I don't like this. I'm able to kind of read the cues around me and know that this isn't safe. But again, if you live in an environment, whether it be just a neighborhood or whether it be situational, so if every single one of your mom's boyfriends sexually abuses you, are you going to have a very high response when you go over and mom's new boyfriend puts his hand on your leg? No, probably not. Now, if one of my kids, they would be like, why are you touching me? There's going to be a very different response from a child who's been traumatized probably more than once. So this is their ability to recognize and respond to danger is being formed. So at the time of Sandra's, she's in a place in her development where it's very plastic, her brain development is. And her reaction to the trauma, coupled with these complexities in her environment, are visible in this hypervigilance that she has in her aroused body states. So when she hears loud noises and she becomes overstimulated, she's unable to determine what sounds and which ones might actually be a threat. So her body is in an almost constant state of arousal. And this is something that we refer to sometimes as toxic stress. It's very difficult for kids to develop normally when they're under that set of conditions. So we're not just talking about their emotional well-being, their ability to physically develop, to be able to have appropriate cognitive functioning and ever be able to regulate those emotions is being impacted. If you think about when you're getting wired, these kids' brains are being wired at this time, and you are wiring this brain to be hypervigilant at all times. You are wiring this brain to be scanning the environment at all times and be nervous at all times. And the longer that state is present, the more stuck it gets. Just like with all of us, when we learn a new skill, the more times you do it, the more likely you'll be able to repeat it. Cultures interwoven. The meaning of trauma is often affected by culture, and the response to trauma is often affected by trauma or culture. So things about like disclosures, who you disclose to, who you talk to, who you don't talk to, report to police, seeking help, going to outside agencies, those things are going to be impacted. Historical traumas. So if you live in a household where your mother's mother was sexually abused, your mother was sexually abused, and then you've been sexually abused, probably going to impact your ability to determine whether or not things are safe and appropriate relationships. And it also affects the rituals and like the grieving and the mourning process that one might use. Depending on your culture, you may express emotion differently than other people. And how people read that and what they do with that information may impact how you are treated. So Sandra's mother is a victim of childhood abuse as well, as was her mother. And it's made it significantly harder for her to engage in counseling with Sandra. And Sandra is afraid to talk to any of the state workers or even her teachers about the things that she saw because she's afraid that she'll be removed from the home. When there's multi-generational traumas that are child abuse, kids learn, how they want to stay in the house. I mean, I can't tell you how many reports you read, and I'm sure you read them, where they say, I didn't want to tell the worker because I didn't want to get taken away from my mom. Like, that is not something that my kids on a daily basis think about. They don't think, I can't tell my teacher what I did last night because I might get taken away from my mom. These kids have learned behavior to try to keep themselves safe. There's challenges to the social contract, so legal, ethical, and issues that affect the trauma response and recovery. So you may want to jump in when we get to some of these. So traumatic experiences are a major violation of the expectations of a child regarding society and those in the child's life. At some point, there is some feeling of betrayal. We've talked a lot about how people kind of get accustomed if they've been traumatized over and over and over again. But knowing that these things happen to you, feeling that they are unfair, or that a mother should not do that to a child or let that happen. And there's often issues involved with the justice system, seeking protection against further harm, and system barriers to receiving assistance.
Jump in here. One of the things I'm thinking about, the parents in our system who have experienced childhood trauma, and then how they interact with their lawyers, how they interact with the judicial system at all, and wondering, just that sense of I was betrayed, so I'm keeping you people at a distance, and I'm never going to trust you, and I'm not going to trust anything you're going to do, and I'm not going to get involved in your therapy. I'm not going to do this, I'm not going to do that. I mean, anybody got any good ideas about how to break that down? I don't have clients, you know that. I'm not the one who's got experience about how to help an adult trauma victim be able to have any kind of a trusting relationship with a lawyer to be able to help them through the system.
Don't take their kids away.
Yeah, don't keep their kids away. Right. Well, that may not be within your power as
That's what they're afraid of.
Right.
That's got to be their number one fear.
Right.
Is that you're going to take their kids.
Right. But if you're the lawyer representing them and they're resentful of you, what?
Alicia's going to take your kids if you don't do this. That's the best I can say.
Wow, that's harsh. Anybody got any other ideas?
Yeah. That's why we brought you.
It's been helpful to me to provide to them some of the resources that are available through the Eyes of the Child initiative that talk them through the process of court so they know what to expect, to say, this is what the court expects, this is what you need to do, and this is the goal that we're working for, so that they are not surprised by this is going to happen and then this is going to happen, and why do we have so many hearings? I found that that's very helpful to provide.
But do you ever feel like literally that you're just not getting through and you're not getting in, and it is because of their own traumatic experiences? So have you used that? I'm just looking for what you've done.
I guess
the symptom that I see first generally is you guys are trying to do this, and they lump their own attorney with the system.
Right.
So I find it helpful at times to sort of explain what's going to happen and what the end objective is. So that they understand that what's trying to be fixed, what's trying to be corrected. And they sometimes set aside the you guys are trying to.
Well, just the other day I was involved, and Gail was there, involved in a deposition, and as I was actually doing the deposition in lieu of live testimony, because this woman's likely to be taken away, and you were there, Scott, be taken away to Wisconsin soon. But there were times when I was asking her questions when literally I could see her disassociate. I could literally, she just left the room there for a minute. It's something about her eyes or something, and I think you guys must encounter that all the time, the lawyers and the social workers and everybody who's dealing with folks. What do you do when you see that? Do you let therapists know? What is it you do with that information? Because I literally, by asking these questions, felt like I was re-traumatizing her, just asking her the question in that situation. I probably was. Gail might not agree because she doesn't like this woman, but yeah.
One thing you have to not talk like a lawyer, just because, I wouldn't understand medical information, all the medical terms and everything like that. I think you have to figure out how you can talk to them on their own level, because, we use the lawyer words and adjudication and all those kinds of things, and I think you have, I mean, you really have to get, I mean, you have to not be a lawyer. I mean,
Not talk like a lawyer.
You talk to them about what's on their Facebook page.
Okay.
Well, I think a lot
I
of
think
people,
you also have to talk to their,
you might ask them what the hell were they thinking putting that on their Facebook page, but other than that.
you and their therapist actually could be a team and work together and let the therapist know, I don't think she understands this or the effect of this, and let's work on this.
I'm going to interject as a therapist, but there's something really easy you can do when people are upset, which is acknowledging and saying, this must be incredibly difficult for you to have this discussion. You know, immediately, and that's why I said I don't expect you, you know, you're not going to be saying to people, I understand that trauma is very complex and that it has, you know, upset your, I understand your,
steps.
yeah, it has 1,200 different steps, and I understand you're dating Johnny's dad again because your danger apparatus was not particularly, you didn't know, you know, like, but if you understand and you have a frame of reference when you're coming out and talking to someone, so when you say, I understand this was very difficult for you, and they say, you don't understand anything about my life, and you're fired, I want to fire you now, you can say, I can understand where you might feel that way. I'm sure that I'm coming in and I'm telling you all of these things, and I'm just thinking about what it feels like to be you right now. You know, you've got to make some kind of personal relationship, and we're going to talk about treatment later on, but you've got to have a relationship to get anywhere.
Having been deposed a number of times, I don't know, that's not the best time to try and establish a relationship, I suspect.
No, it's not.
But one of the best, and research across medicine and law and casework is when people feel understood, they are much more open to influence and to hear you. One of the problems, and my kid is one, so I can say this, with attorneys sometimes, is that they talk more than they listen. And if you really want to connect, and it's not guaranteed by any means whatsoever, with your clients, and again, deposition is not the time to try and start something like this probably, is when they really think you, not that you agree with their situation, even if you're their attorney, but when they think you understand it and get it, which means you can hear them and reflect it accurately, there's at least more of a chance they're going to feel more comfortable with you and be more likely to listen to what you have to say.
And taking the time to have that relationship. So I know you all get like last minute notices, but when you are in a crowded hallway, and Lincoln's a little bit better, but I know there's 2 people here from Douglas County. Like, I always see people in the hallway trying to talk to their client, and there's people rushing past them, and they're like, so I heard you were assaulted and something happened, and you know, then they came and took your kids away. I'm thinking, oh my, like, it makes me as a therapist want to faint, thinking how uncomfortable this person is, and you're just boom, trigger, boom, trigger. Let me say all the buzzwords that are going to make your arousal system just light up, and then they go, God, I got so mad in court. Like, I have no idea. She's lost it. And I'm thinking, because you pressed every button before you went in, and then you expect to not have an explosion. Like, these kinds of things, like taking 10 extra minutes, or if you don't have 10 minutes, don't get into it in the hallway. Do not get into the meat of things in the hallway. So, and not being surprised when these things happen, too, I think. Go ahead.
I will say that there have been times in my career when I have run into somebody who just, you know, has seen the system, knows everything. It doesn't matter whether you relate to them or not. And basically, I think with those people, you just have to lay out the alternatives and say, you know, he said, you tell them what's going to happen. But not just what's going to happen, because what's going to happen is what you predict will happen. What are some other alternatives, other ways you can deal with it, or other ways you can look at it? Ask them if they have other alternatives, okay? I mean, the system isn't perfect, but it's all we got, or it's the best we got. But, you know, sometimes there are other ways to look at it. It's not convenient for everybody, and it's not easy, but maybe it's the right thing to do for that board at the time. And so, I mean, you don't run into those, in my opinion, you don't run into those real often, but once in a while you do. And, you know, sometimes that's worked, but it creates more work because it usually means that you have to ruffle some feathers or you have to
Get creative.
take an extra 15 minutes with the therapist, or you have to, you know, it requires more work. But just because they say that, you know, they don't believe in the system and everybody's full of crap or whatever, you know, you're probably not going to change their mind at that point, but sometimes that's a way to address it.
Yeah. And I think just being aware generally when you're in a court proceeding about pushing buttons and triggers. You know, when we know that people are going to re-experience things, we had a drug court hearing that was not in this county, it was in a different place. And well-meaningly, everyone's having a discussion about this woman's trauma right in front of her. So what do you think is going on with her? I mean, first of all, we're talking about her and she's in the room like she's not even there. Secondly, you know, none of us are personally affected by it, so we could talk about the details of it, but it's all going on in front of her. What do you think happened when it was her turn to talk? She stood up and said, I'm done. I'm going to relinquish my parental rights, and ran out of court. And then everybody stood there and said, gosh, what happened? And I'm thinking,
duh.
Duh! You know, like so then we have to bring back, though, and there needed to be some repair that had to be done at the next hearing, where her attorney had to say, we were not doing a very good job of taking care of you. We realized that we said, you know, you got to repair that relationship when you do things like that, and say, that must have been very difficult for you to hear all these people talking about you and remind you of all of these things. That must have been really awful. And then understand that that's why she ran out. She didn't run out and want to relinquish because, you know, she really wanted to give up. She became completely overwhelmed physiologically and emotionally and ran out. So not having the worker there saying, well, last week you said you wanted to relinquish, here's your paperwork. That's, you know, we need to think in that context.
I think something that's pretty simple and straightforward is because sometimes people that have experienced trauma are really unlikable themselves because of all of their symptoms, but just to remember it's a human being. This is a human being, and I'm a human being, and I mean it can trigger maybe a little more creativity in terms of thinking about them, because it's like that's a very basic common ground. So even without anything very specific, it can change one's attitude toward the person in front of them and how one behaves with them.
Right, having a little bit of empathy. This fits in really nice with our next slide because this interferes with our inability.
Is this it?
This is the 12th concept.
Woo! We're at the 12th one. Yay.
So
pretty soon we're on to repair.
yeah, we'll get there. Working with trauma-exposed children evokes distress in providers and makes it difficult for them to provide good care. So when you have worked in this field for a long time, what does it do to you? It makes you not see people as human beings. You're thinking, this is the 10th kid I've had this week that has, you know, done stupid stuff to get locked up, and I'm so tired of why can't he just, you know, stay there? Why does he keep running away? Or can't he just behave in school? What else does it do to us? I used to see 10 clients sometimes back to back, and all of mine were child abuse and neglect. What do you think I was like when I got home at the end of that day? Like drool could have come out of my mouth and I would not have noticed because I just was emotionally blunted from the day. Okay? What happens to all of your bodies when you're in a court hearing like the one I described and mom starts yelling and she's running for the door and it's your client? What happens to your physiological arousal? You all sit there calmly and just say, oh, well, you know.
There it
No,
is.
you know, like you're upset. And we feel helpless as providers because these people, they've got a lot of complexity and it's difficult to work with them. And we may have gone to great lengths to do all these wonderful things and provide them with options, and then they do something that seemingly messes up the entire thing, and what do we all want to do? That's it. I'm not calling her back. I told her 10 times if she didn't do what the judge ordered that I'm just not talking to her anymore. Okay? You have just gotten sucked in to, her trauma response, and that is not healthy. That's not going to be good for you. It's not good for your client. So we'll talk about Sandra's therapist, what she does. So her therapist is frustrated, and they come to the appointments, but they're late, and she's got a really busy schedule, and maybe she's not very patient in the first place, like I wasn't when people were late. And she's tired from going to work with her mom, so when she gets there, the therapist starts thinking, I could so take better care of Sandra. Like, I should just take her home with me. Her mom, she takes her out all night long. I would have a bed for her. I would be home for her. She's having rescue fantasies. That therapist needs to discuss that in supervision. And so she eventually realizes this, and she's able to help Sandra. What happens if Sandra's therapist never does that, and this is the way she sees Sandra and her mom? How helpful is she going to be to mom? And if Sandra is 3 years old, and I know this because it happens with our therapists, what if Sandra starts coming to the therapist more often when they're in a session where they're doing play, like dyadic play therapy together, what does the therapist start to think? Sandra likes me better. See, she's more attached to me. There's something wrong with her mother. But it's her job to make sure that Sandra and her mother are going through that experience together. But she can't see that if she has got this going on. So we kind of have walked through this example of Sandra, who's in an abuse neglect case, but we decided that we probably should talk about a different kind of case with an older child. So I'm going to set up the case for you, and then I'd like us to just kind of have a short general discussion about how some of these things are going to apply. So Bobby's a 13-year-old male, and he's in the court system due to truancy. What do we know about truancy?
It's messy.
Well, besides it's messy, what did we learn today that truancy might be a symptom of? Trauma.
Which is why it's messy.
Right. He's getting caught with marijuana at school. What do we know about substance abuse? Trauma. His mother used to work at a convenience store, but she's fired for missing work several times when she had to go pick Bobby up and go to court for Bobby. So in the context of trauma, it's starting to impact their financial situation. It's impacting mom's work situation. Bobby has a learning disability. Trauma. And he was just diagnosed in the past year, and he's put on medication for ADHD when he's 9, but he's still showing symptoms of impulsivity and hyperactivity. If Bobby's 13 and he got put on medication at 9 and he has the same symptoms, is it working? What should somebody be doing about that? You're all just going to let Bobby keep taking the stimulants and he's already hyper-aroused. He's going to be truant more often then. Yeah, somebody's going to have to advocate for Bobby to be getting a new, look at that. So what else do we know? That ADHD might look a lot like trauma and PTSD. Yeah. So Bobby, we find out, has witnessed multiple incidents of domestic violence between his mother and his mother's boyfriend. And his mother and the boyfriend have separated multiple times, but the boyfriend's living back in home. And you're all, initially, before you came to this, and after today, when this starts to fade, you will say, why would she let him back in the home? Why did she let him back in the home? She might have needed him financially. What else was it? Protection. Okay. Protection. She might feel like she needs him around. She feels unsafe herself. Does she need help with Bobby?
Probably.
I mean, she's frustrated. I've lost my job because of Bobby. I'm going to court for Bobby, and he won't stop smoking pot, and he keeps running away from school. Like, I can't do anything about this. I'm going to bring this boyfriend back in the house to set Bobby straight. So Bobby's decided that he's going to stay away from home as much as he can, but he's also worried about his mom. So Bobby's exhibiting some anxiety, and he can't sleep because of it. So he's smoking the marijuana to ease his anxiety about his mom getting hurt. Bobby also has 2 younger siblings that he leaves at home sometimes to go smoke marijuana with his friends, and at other times he's been in charge of these siblings while his mom works. How do you think Bobby feels about, and we talked about siblings a little bit, how do you think Bobby feels about leaving those siblings at home in that situation? Guilty. Yeah. He's going to have some significant guilt. Now, Bobby's 13 and he doesn't have any coping skills and he doesn't have any support. How's Bobby going to deal with his guilt? He's going to smoke some more marijuana, and he's not going to go to school because he can't concentrate, right? Okay. And Bobby has a father, but he's only met him 2 or 3 times. What might Bobby start to do about this father that you probably all see on your cases? He's going to start trying to get in touch with his dad. He might idealize that relationship. He's going to start, reaching out for some of those things, which might complicate your case. How else might some of these core concepts apply? We've talked about it a little bit through, but did we miss anything with Bobby? Anything that you can think of? Okay. Sure.
Now, there's always been a big debate about whether kids are ADHD, and of course it's been way overdiagnosed probably. But I think there generally are some kids who are ADHD.
Sure.
Who medication helps. And I know that we're talking about trauma, and of course that this is where you're headed, and that. But sometimes, could it be that it's a medication problem that needs to be
Well,
addressed?
sure. Yeah, but Bobby's been on the same medication from 9 to 13 and has the same symptoms.
Well, from 9 to 13, kids' hormones change a lot.
Yeah.
And their medications need to change a lot
Right.
when they're ADD.
And right. So regardless of which, somebody needs to be taking a look at that. And that was my point, is that if you have kids, and we'll talk about medication a little just briefly later on, but if you have kids on your caseloads that are on medications, and whatever the target symptom is, and there should be one, you don't treat PTSD or ADHD with medication, you treat the symptom, which is hyperactivity.
I disagree with you on that, because there are some kids who are ADHD, and when they hit puberty, their medications will go all over the sun, and you have to have somebody monitoring that.
But that's
very closely.
That's what I was just saying.
Yeah. So it could be the trauma thing, or it could just be that the medications need to be adjusted a lot.
It could be, but you need to look at those 2 things. I think when you have kids that are in a court proceeding that did not come there, Bobby is coming there for his truancy issues and what have you, but we know Bobby has a trauma history too. And Bobby's not getting any trauma therapy. Bobby's not dealing with any of that. Bobby's getting medication only for ADHD, and that also would be inappropriate. That's probably a whole nother section.
But let me ask you this, okay? He was doing okay up until he started smoking the marijuana, even though he had trauma, right?
Well, we don't know that necessarily, but
maybe he was just burying it, okay?
So.
Maybe it's coming out or whatever, okay? Or maybe the medications are not acting right because they don't when they hit puberty. It's a real I don't know. It's very difficult.
I think we're on the same wavelength, though.
Understand. We don't have a lot of access to that in Nebraska. But, well, anyway, go on.
I think we're saying the same thing. Somebody needs to be monitoring Bobby's medication. It doesn't matter if he has ADHD or PTSD or what Bobby has. If Bobby's been on medication for a long period of time and it's not changing the target symptoms and it's not working, somebody should be looking at why that is.
And you know what I've experienced with the courts is that the 6-month review rolls around and they say, oh gee, he's acting out, oh gee, we need to have a med check, and they have 1 med check in 6 months. You know, kids who are going through that and have those kind of symptoms, they probably need to be checked every month or every at least 3 months. And we don't do that in Nebraska because there's not a lot of access to doctors, and it's unfortunate. But I hear you say that we should, you know, definitely look at the trauma, and that's okay too. But sometimes the easier solution would be to probably get the meds right if that's the problem, because otherwise you're going to be doing therapy for years.
Well, the problem with trauma, and this is kind of what we started out with, is that it's not going to go away. So if we don't treat Bobby's trauma when he's 13 and we just medicate his symptoms, even if we medicate the symptoms, Bobby still is going to have some issues with the way that he thinks about the world, the way that he's in relationships, the way that he copes with stress, that are going to make him predisposed, you know, to having some difficulties later on in his life. So trauma doesn't go away. It gets treated. And if it's never treated, you can't medicate it.
Well, let me ask you this, okay? Because this is something I've always wondered, if you don't mind me interrupting your lecture here. Sometimes I think that it's best to let sleeping dogs lie. Now, I understand his relationships and stuff may be not quite 100% right. And I'm not saying, you know, if he's going to be a pervert or something, that's right. But on the other hand, sometimes I'm not sure that delving into all this stuff is really helpful.
Well, the research tells us that it is. You know, I think that it's difficult for us to think that you want to unearth things that are painful, but there is a physiological change. These kids have a body response. They have memories. It affects their whole world. And so to let sleeping dogs lie is really just letting it come out later on. It is painful. You know, it's one of those things, you know, there are certainly a lot of things we do in life that are painful, but the end result, you know, is better.
I had somebody tell me once, I don't know if this is true, and maybe since you're an expert in the field, you can let me know what your take is on it. But they told me that when the kids are really young, that sometimes they forget it if you don't keep reminding them about it.
No, they don't. They may not have the language to describe the things that happen, but you should look at Bessel van der Kolk. Dr. Bessel van der Kolk has a great quote that's "The body remembers trauma." And he talks a lot about the physiological impact of trauma on people and abuse. And he's got some really interesting research, but it doesn't go away.
Well, certainly once they're old enough, it wouldn't be, you know, but when they're really young.
When they're real young, that baby that we just saw, I think you'll see when I show the tapes later on what a different baby that is. And sometimes it is a difficult concept to process, first of all, that babies have thoughts and feelings, and then on top of it, that they could, you know, be impacted by this type of trauma. It's difficult for a lot of reasons, because it's emotionally difficult, because it's not the way that we see infants and toddlers in general. But it fits more with what we know from education and other fields, that is the time when all of their neurodevelopment is happening. So they may not remember, they may not be able to put into language the things that they saw, but they have body memory, they have physiological memory. And I got to move on, but look up Bessel van der Kolk, and he's got a lot of research about that. So this is a quote from one of our parents about child-parent psychotherapy, because we're going to move on now and talk about assessment and treatment. Talking about her therapy that she had, and talking about how she wasn't thrilled at the beginning, but that at the end she's wanting to thank her therapist. This is supposed to be my hopeful, after Sandra depressed you all, you're supposed to be all like awe-inspired by the hopeful quote. So we're going to fly through the assessments pretty quickly so that we get to the rest of this. These are some common assessments that you might see. You don't know how to do them all, and that's fine, But these are things that we're going to tell you these are good instruments to use for trauma. You might see more commonly things like the trauma symptom checklists, because those are pretty easy to use. And the last one that I'm going to talk to you about is the one that I said that any of you can really fill out. So if you want to open up your packet, inside there's 2 copies of this child welfare trauma referral tool. And we aren't going to have time, like I had hoped, to kind of go through this, but it's a really simple form. It's got check boxes on it. And you're able to, if you look at the front of it, you can put, yes, I know that this has happened at the developmental age, and it gives you a bunch of different things that can happen to a person throughout their lifespan. I suspect that it's happened, or no, it hasn't happened. It gives you a really nice picture of the kind of trauma that someone may have suffered. It's relatively not intrusive, it's short, and it's a checkbox. You know, you don't have to get details, or you could go through a case file pretty easily with something like this. We talked about training child welfare workers to use this tool because I thought it would be a really nice way for them to show, there's a chart you'll also see at the end, about why they make a trauma-specific referral. Because they may not send this child to a therapist that is trained in trauma. And this gives you a little kind of decision guide for that. You don't have to be a therapist to administer it. It's really pretty simple.
So are they using it, Jenny? No.
Probably not. They are when I say, you should have. Here's, like in our voluntary meetings, so you know this happens, they say, I say, why isn't the 4-year-old in therapy? And they say, why would they be in therapy? And I say, well, have they been traumatized? And they say, no. And I say, how do you know? And then they all of a sudden want a copy of this form. That's kind of how that goes. But
you know, now I've been thinking that's one of the areas I think that we fall down in, quite frankly, a lot is, you know, I'm so focused. I mean, I just have to say, I am so focused in a case on the parent's behavior. And I'm assuming that the guardian ad litems should be focused on the effect on the children. And so I'm not thinking about this, but I'm hoping all the guardian ad litems are out there thinking about this is, what is my kid, the kid I'm the guardian of, what are they getting? And if you have police reports and you've read the case file, you probably can fill out the screen yourself and then work with the caseworker who is way newer than you are and doesn't know as much as you do many times, and you know, try to get that trauma screen, try to get that trauma therapy for that child with somebody who actually knows something about trauma. We'd probably be a whole lot better off in our cases.
Do it with foster parent too. You could sit down. I mean, if you're not comfortable, you know, some of these other assessments require a therapist to sit down and be asking questions and going through, but you can do this one a lot through records or from collateral reports. So if you're not comfortable with that kind of, you know, face-to-face discussion about their trauma, that's all right. You know, you can get that information. So.
And if anybody ever asks me, you know, okay, I want to do this trauma screen and here's what I know so far, you know, is there anything else that you know that, you know, isn't in the factual basis or that, you know, you haven't brought forward in court, you know, I'd be more than delighted to share any information with a guardian ad litem who says, I want to make sure I've got accurate information about this trauma screen. So, you know, if anybody ever asks, I would give away, let me tell you. Bingo.
Bingo. We're gonna get to that. That's why I like this tool, because you're able to say, you know, they might put in there that, you know, there's trauma or what have you, but if they don't do one of those assessments, it's a lot of clicks to get back there. You can ask for that to be included, and we'll get to that a little bit later on. Or if you have this, there's a decision tree at the end of it, and you just go through, and you can say that this kid must need some kind of a trauma referral.
What kind of, I guess, treatment options are available? Because
We're getting there. We're getting to that part.
Good question.
Good question, though. Yeah, because we hear that a lot. So just in general, if kids, you suspect they're traumatized, the treatment should increase feelings of safety, attachment, and self-control. If there are things going on in treatment that you're hearing about and you're thinking, these things are not happening, or the second one, if they're doing trauma work without a relationship, they're bound to fail. If you don't have a relationship with a child or a parent and you're trying to do that kind of work, it's not going to work.
Jenny, are you willing to tell a little bit about having kids who have been through a traumatic experience be involved in the Behavin' program? Well, or will you get there?
We talked about it. I mean, that's a good example of Behavin' is a wonderful program. However, if you have a child who's been traumatized and is not in trauma treatment and doesn't have a secure attachment relationship with any other human being, you're going to see an increase in behaviors. Because you're looking at a rigid behavior program that takes away control, right? You don't have an attachment, and you're going to see a skyrocket probably in behaviors. Or what you're going to see is that Timmy can behave at Behavin', and then guess what happens when he goes home? Yeah. And that's not necessarily because the parent isn't attending, but it's because we're not addressing that trauma. So when Timmy's mom is a trigger, because I think you were talking about this, like mom's the perpetrator of the abuse and Timmy's mom is the trigger, and they haven't done any relationship work to repair that relationship or focus on that trauma, she can be the best timeout mini mom ever, and she can learn all these skills, but she is not going to be able to apply those skills. So when you're looking at programs, if there are things that you're saying, I don't know, you know, Timmy seems to have gotten 10 times worse since we placed him in this program, maybe there's something that's not going on. Either a relationship's not being formed, or maybe Timmy's not ready for that kind of care. So evidence-based treatments, and I'm going to focus a lot on the same kind of treatment because they have the most research. And I'm going to focus quite a bit on this one because it's newer and it has to do with an age group that's probably undertreated. We're going to talk about child-parent psychotherapy, which would be what we do in Project Safe Start. And here's the answer to your question. We do these in Family Drug Court. Medicaid and Magellan now approve parent-child interaction therapy and child-parent psychotherapy. They currently have no one on their panel because of the restrictions that they put on it, but we at the center are kind of working with them, and we had a very good meeting the other day. So I'm hopeful that we'll have some providers that are on there, or if they've been court-ordered to do this type of therapy. I frequently get phone calls from caseworkers, and we'll find them a therapist that we've trained. So, and then the services have been paid for. So it should get better. There's some other parenting groups up here: Incredible Years, Parents as Teachers, Nurturing Parent Programs, Healthy Families America, and Circle of Security. We don't have any Circle of Security providers either, but that should be coming. So it's always easier for me to show you a video of what we do in child-parent psychotherapy than explain it to you. Again, because of the discussion about babies and how we all feel about doing therapy with babies. I can't tell you the number of rooms that I've been in, and I give this whole discussion about infant and toddler trauma, and everybody goes, and I know they walk out and think, she needs some therapy. Like, I have no idea what she's talking about. What do you do with these babies? So now that we have some tape to show you, we found that to be very helpful. What we saw before, this is the same case. So about 12 months old, mom's got substance abuse and domestic violence. The child's witnessed the domestic violence. The mom has a lot of her own trauma and no family support. And I'm going to show you, and I really have to warn you, this video, if you're a parent, is really distressing. So the baby is 12 months old, and what did we learn about this baby before? What should she do when mom leaves the room?
Cry.
Really upset, right? So at the end of our assessment, what they do is they have a separation for 3 minutes. This is going to be the longest 3 minutes of everyone's life. They say, leave the room as you normally do. You'll hear her and the therapist having a discussion about that just a little bit. How do you think people normally leave the room? They walk out. I was always shocked. I thought, like, you realize you're being evaluated, and I say leave the room as you normally do, and the best thing they have is to walk out.
What would you normally do? Just normally just hand her to, okay.
Mom's gone and she's in the room with a stranger. And you'll notice, is she interacting with the stranger at all? Did you see her this active before in playing with toys? What do we hear when she's by herself? She's vocalizing. She wasn't really doing that before. Mm-hmm. She's not moving around at all. I know. Well, and that's the problem. I think that's a good, when Barb just said, I've never had kids like that. Like, sometimes people will say, this is great. This baby just sits here and plays with 2 toys. It's great. They're such a good baby.
That's why God created playpens.
Yeah. Yeah. Yeah, where are we guessing she probably spent a lot of time?
In a playpen.
But it also shows her potential because she is picking up different things. She's examining them without any cues. She's curious. She's responding.
She does more of that when mom is out of the room, which kind of tells you about that relationship. She was saying she's examining things and vocalizing and doing these things that normally kids her age would be doing with the parent in the room.
Is that a telephone?
It's a telephone or a cucumber or something. Yeah, anything that size becomes a telephone. Does this feel like a really long 3 minutes? Because we don't leave them longer than 3 minutes. Here comes mom. We like this. There's a little bit of a smile. Yep, really quickly. Watch what mom does. I hope we get to it. I can't remember if I cut it off or not. Good eye contact. Oh, you didn't get to it. Guess what she did with her right after that eye contact? She turned her around and set her in front of her so that they're not facing each other again.
Interesting.
So that is part of the assessment, and I'm going to show you a follow-up of what happens when we did child-parent psychotherapy for, I think it was about 6 weeks. I think there were 6 sessions. And this is the same baby and this is the same mother. And I'm not going to kind of get into the mechanics of all of the goals and what have you. We could spend a whole time. But what you're going to hear is the therapist narrating in the background, and it's an intervention called Speaking for Baby. So the therapist is going to narrate and give developmental guidance. She's going to talk mom through some of these things and encourage mom using the baby's voice. What's she doing that she didn't do before?
I'm showing you, Mom.
She's referencing, yeah. Her and Mom are facing each other. Do you hear how vocal Mom is all of a sudden, 6 weeks later? And she's doing it over and over again, like the baby likes.
I can't remember what I was feeding her, but I actually grabbed it and ate it. She just looked at me like,
Supposed to do that, Mom.
I got to fast forward a little bit because we don't have as much time as I thought we would. What I want you to see is we're going to have an accidental separation. And this is 6 weeks later after 6 weeks of treatment. Oops, it's too far.
well, actually, look, I don't know what these things are. Actually, I just remembered.
Look at her head.
We got this.
She says, Mom, hurry up, for goodness sake.
And look at her, look at the therapist.
Huh? You want butternut squash and macaroni and cheese or harvest vegetable fruit?
She's like, get her back. What are you?
Okay, what do we got to do first? Start with anything else?
Says, Mom, you're taking too long. I've never seen meals like that. They come in a packet?
Yeah. Stephanie brought them.
I love how she looks through there like, is someone going to do something? Like, my mom is not here, and you person are just narrating. Like, do something about this. But she didn't do that before. Coral was in the room with her before, too.
Yeah, Stephanie brought them when she came.
Mom, I'm mad, and mad.
There we go. She's lost body control. So if you've seen a still face video, she loses her posture. This is what a baby should do when separated at this age. And I want you to watch the recovery because she's really upset. Like when you're flopping around like this.
It's yummy and nutritious. It's salty. Now, Mom, if you make that face.
Look how fast she got calm. It took her, I mean, when Mom sat down on the chair, she's okay. She's back engaged. I got to fast forward a little bit because we don't have as much time.
She says, Mom, I'll do whatever you do. She says, I'm showing you, Mom. Can't you see?
Oh, I might have double looped it. And maybe I don't have it. I don't have it. So she eventually takes the bowl and starts feeding herself with a spoon and things like that. So that's 6 weeks later. That's a relatively short period of time to go from what you saw before, which was a baby with really flat affect, who didn't have much connection or attachment to mom, to this. And what we talked about earlier is that positive attachment is going to be a buffer for the trauma. So does everybody notice the difference in the two babies? They look completely different. So the babies are my favorite because that's what I talk about all the time. I could spend all day talking about it, but we do have to treat other kids. So ages 6 and up, you're going to be looking for trauma-focused cognitive behavioral therapy. There's a lot of variations of that. Cognitive behavioral interventions in the school. You might see some people starting to use EMDR with older kids. Cognitive behavioral therapies are going to be interventions related to these activities. So they should be teaching stress management and relaxation skills, exposure strategies, not to actual trauma, but to triggers of that trauma, so things that are reminders. They should be working on something called a trauma narrative. We do that with older kids in child-parent psychotherapy. They do a joint play trauma narrative. So they'll go ahead and work through some of that with the parent, where the kids usually spontaneously will begin acting out things. And what we found before was if I'm doing play therapy and I have a small child acting out a trauma narrative and my response is good and I'm calm and I'm able to comfort them when they're distressed and teach them to regulate and be calm, that's great. But then what happens when mom comes in? They can't do it. You know, they've worked through and done all of that with a therapist, but the parent hasn't been there. And that's the other great thing about therapies like trauma-focused cognitive behavioral therapy, that they do involve parents when appropriate, whether they be the offending or non-offending parents. But when the therapist deems it appropriate, they go through the trauma narrative and the parent is part of that therapy. The Child Advocacy Center has a list of approved trauma-focused cognitive behavioral therapists that have follow-up calls and things, so that'd be a good place to look for that. Medication, we've already talked quite a bit about. It's not going to treat the trauma, it's going to treat symptoms to the trauma. So there are symptoms that sometimes need to be treated in order for people to do these kinds of therapies, because they may have so much difficulty regulating their emotions and containing kind of that physiological arousal that they can't participate in therapies. So some of the symptoms that might be used for are anxiety, nightmares, insomnia, or any other secondary symptoms that you might be seeing. Again, you could probably spend an entire day talking about medication. We want to look at things to decrease ongoing stress, so creating safe and stable living environments. So when we move children multiple times, that's a problem when they've had trauma. We're changing things up. Sometimes with other kids we'll use, older kids will use group therapy or dialectical behavior therapy. But they may need to do some work before they do the trauma therapy. They may need to do some basic work on getting some coping skills, and they may need to be in that stable environment. I'm flipping through these relatively quickly because this is what I wanted to get to. These are 2 websites that you can go to look up evidence-based practices. So if you went to this national registry or the California Evidence-Based Clearinghouse, like the California Evidence-Based Clearinghouse, you could type in child-parent psychotherapy and it will tell you the number, a ranking research-wise, like whether it's a promising practice or whether it's evidence-based, and it'll give you a relevance to child welfare. So like child-parent psychotherapy, the highest rating you can get research-wise is a 1, and it's at a 2 right now, because there's still emerging research, but we would call that an evidence-based practice. But the relevance to child welfare is a 1. It's the highest rating that you can get. So you can go to these 2 websites if you're, one of your clients says, I'm doing X therapy, and look it up. And it gives you a really nice comparison where you're able to just, you can compare 2 different therapies. It gives you kind of a short breakdown about what they are. So as if all this wasn't complicated enough, and we talked a little bit about this, the complexity of this is that the birth parents, the parents that you're dealing with, may also have their own trauma, and they may be experiencing trauma symptoms as well. So just real quickly, we're going to talk about some signs. Avoidance, so which also may include you. They never call me back. Don't you want things to get better? You never call me back. Feeling emotionally numb or disengaged. Some of them are the same as for kids. Hyperarousal, emotional or behavioral agitation. Re-experiencing of events which they're probably not going to report to you. Feelings of powerlessness and helplessness and hypervigilance. So watchfulness, alertness, edginess. And we want to keep these in mind because they sometimes look like things they aren't. So those symptoms and that trauma influences the way that people are going to interact with you. And sometimes it looks like noncompliance. How many of you have been on the other end of this phone call? You're just, it's like a well-meaning, you think you're going to have this nice conversation with your client, and all of a sudden they are screaming at you. Or you're asking them to do something that you think is relatively simple. Show up to your visit. You have to go to your visits. If you were the mom that we did with the CPP, the first tape, would you want to go to those visits? Probably not. After 4 or 5 of them are being rejected, you might not want to go to those visits anymore, but you're certainly not going to say, or have the ability to say, I just feel really rejected when she doesn't pay attention to me, and I can't handle it emotionally because she's a trigger for her, dad who I was in a domestic altercation with. You're going to say, I couldn't get it right, or I don't know what happened, I just couldn't get there. So there are things that may look like noncompliance, and they are actually kind of avoidance behaviors because there's some trauma. It also affects their ability to respond to their children. What did we see in tape number 1 with mom? In her ability to read baby's cues. She's really terrible at it. She's not in tune with her. She's not able to see what the baby needs or empathize and think this is what the baby must be feeling. But in the other tapes, in the follow-ups, even when she's got to be separated from the baby, we hear her using her voice to kind of try to soothe her. We see her, talking in that kind of high-pitched motherese voice. It also interferes with their ability to react to a child's behavior in a calm, thoughtful manner. So again, when Sandra's been up all night long and you've been dealing with her and she doesn't want to put on her shoes to go to preschool, you might have a parent that is going to be screaming and yelling at Sandra. Now, we all probably do that at some point. Of course, never me, but what does that do to Sandra, though? What's the difference between me sometimes saying, I've asked you 9 times to put on your shoes, we're going to be late, and Sandra's mom getting loud and saying, I've asked you 9 times to put on your shoes, we're going to be late, and screaming at Sandra? What happens to Sandra? She's triggered, yeah. And how compliant do you think she is then with mom's request when she's triggered? She's, again, in that kind of hyper-arousal, the fight or flight state, so you're in for a big fight. Mom then feels powerless and helpless, and we go round and round and round. They may not be able to make appropriate safety judgments. We talked about that a little bit earlier. There may either be an overprotecting or an inability to recognize those dangerous situations. It's very difficult for people who have been sexually abused to recognize the signs in a perpetrator. Why would that be? You can join in since you're here.
Well, perpetrators are really, really good at hiding.
Yeah.
Number one, and number two, denial.
Yeah. How painful is it?
Sometimes law enforcement isn't very effective.
Right.
But it's not their fault. They don't have the money, they don't have the technology. And so, you know, it's factors.
And it's an awful thing to think about. Like, no one goes through life thinking, you know what I really want to think about is that guy that I sent my kids over to have him babysit, that he molested my kids.
Or the guy that I love.
Yeah, or the guy that sleeps next to me every night is doing something to my 5-year-old. Now, if you couple that with a birth parent who has trauma and has also been sexually assaulted or molested, there's going to be huge avoidance at that topic. So when the kid does come to say, you know, something's not right, that trauma is going to be a big influence. They might not be able to meet the child's needs emotionally or support them in counseling. One of the things we do in child-parent psychotherapy is act as much as a support to the birth parent and their trauma as we are to the child. And we look for things like, we call them ghosts and angels in the nursery. So we look for things that have impacted their parenting in a negative way or in a positive way. I'm going to fly through the rest of these so Alicia can get on to her part. It affects their ability to form trusting relationships, to moderate or control emotions, to make decisions and plan ahead and manage life stresses. This makes your life very difficult because you need them to do all of these things to close their court case. So keeping that in mind. Keeping that in mind, what do you do? So for kids, treatment choice is going to be really important. And you all playing an active role in that and making sure that if there's trauma, that someone is aware of it. I can't tell you how many times that meant my time was up, but we're going over. I can't tell you how many times, you know, you get all the way through a case and then someone will say, oh yeah, well, you know he was molested, right? No. That makes a big difference. Minimizing changes. Providing some kind of stability and safety for kids. Helping them to have some kind of normalized experiences. You know, play is healing for kids. They need to have these kind of fun activities. And when we're talking about older kids, sometimes I think we get in the, you know, if you take away everything that is enjoyable in someone's life, they don't have a lot to lose at that point. And pay attention and look for those symptoms of trauma. If you're seeing them and you don't know for sure, but you're thinking, something's not right about this, you know, this kid just started doing all of these things at age 9. And up until that time, we're on a kind of a normal developmental trajectory, things were going fine. And ever since this happened, you know, his behavior has really changed. Empowering the parents kind of by asking them what services they think might be helpful for their child. And it might be that you're having to give some options and say, you know, these are the kinds of things that we have to offer. How do any of these sound like something? And be ready for them to say, they don't need anything. So, because that's that avoidance. I'm going to hold just for 1 second because I want to get through some of this. So I've got to, and then I maybe in break in between us, we can do a question. We want to build on what worked before for parents. So if there are things that you know have worked for them to do before, if there are people that they've worked for that they've done well with, we want to try and do that again. They may need a trauma assessment. And we don't want to assume that a mental health assessment is a trauma assessment. I think someone pointed that out, that they don't see those things in there. So you might have to make a specific referral or request and say, you know, I need this to include a trauma assessment. And asking questions. Therapists that you're working with should be able to answer questions that are not only case specific, but they should just be able to, in general, give you some kind of framework to work with, you know, about what's going on with someone who's got some trauma. So calling them or talking with them about what's going on in a case, and Alicia's going to talk about more of that. And if you have a trauma assessment, this is all in your PowerPoint, these are some of the things that should be included in there. So their past or current functioning, strengths, self-report and clinical interviews, the presence or absence of post-traumatic stress reactions, and then recommendations for additional services and assessments. So you have to know what exists in your area and where to go to get it. I know the Child Advocacy Center has a list of therapists that are trained in TFCBT and other traumas. We can help. You can contact me if you have a kid under 5. We want to watch out for co-occurring disorders and make sure that they're getting appropriate treatment for that. And keep in mind, someone mentioned bridges out of poverty, all of those other obstacles that you may be dealing with. I've got 2 more slides, but this is one that I've found a good tool as a therapist, and I think that it might translate well. I went to a talk one time when she was talking about attachment, and she was talking about being a steel box with a velvet lining. So being able to hold people accountable, but having in your mind all of these things that we've discussed about trauma and about people's life circumstances that might make them act in the way that they do. Keeping in mind that they're a human being and having some empathy for that, but also being the person that's able to say, you know, these are the things that are going to happen if we don't get to therapy, you know, if you're not following through with the court orders. Building on their strengths. And then just the last thing to remember is that court can be confusing, intimidating, and disempowering for people. You all are used to being there all the time. Your clients are not. They're not very well prepared to be there, and they often feel ganged up on. And we use language that they don't understand, and we talk very quickly, and we're all in a busy hurry, rush to get someplace else. And this is their life. You know, these are their kids that they've just lost. And I, in all of my years of clinical practice, even with some of the most terrible, horrible cases, have not found too many parents that had, I mean, there's been a couple, but that had no guilt and shame in what was going on in that process. And that's really difficult to break through, you know, and they're in a bad spot. So, did you still have your question?
Well, I do, and maybe it's a statement. You seem to know both sides of the issue, and I'm sure it's real helpful to you in your practice. I have found that, well, let me ask you this. You know, in a situation where the mother's got the abusive boyfriend, you know, and he's abusing the kid or whatever, and, okay, you get rid of the boyfriend, and they dismiss the case, and then 6 months later you got it back, she's got another abusive boyfriend, and abusing the kid. What about educating the kid on how to deal with the bad boyfriends? Because they're probably going to come back. And dealing with life as it is, rather than taking the kid out of the home and dealing with all that, or trying to educate the mom if you can't change your mind. What about educating the kid? And I'll tell you why I'm thinking that. Because what I see with the technology and the perverts that are running around, I think that's the answer. It's, and you know, law enforcement can only do so much. And, you know, it shouldn't have to be on the kids. It shouldn't have to be there. But it looks to me like that's probably what it's coming to.
We certainly do some education of kids, and actually in trauma-focused cognitive behavioral therapy, there is a component about kids working on how to recognize safe and unsafe situations, and we want to teach them that. But I mean, if kids could take care of themselves, they wouldn't have parents. And you're right, they shouldn't be in that position if it continues to happen over and over again. And I think not only do you have a human cost, but repeated traumas, repeated situations where people are helpless and not able to protect themselves are going to create generational traumas. They're going to create mental health problems. They're going to create substance abuse problems. So I recognize that we need to educate kids, but I don't think we can depend on them to protect themselves.
Well, you know, what I see, and maybe it's you know, maybe it's not prevalent in some areas, it's where we're at. It's very prevalent out where we're at. And I don't think law enforcement has either the tools or the money or whatever to deal with it, and it ain't working. You know, what they used to do is they used to have the situation in school where they say good touch, bad touch, we'll teach you that. If you have problems, you call the law enforcement or the social services. They can't handle it all. And something's got to be different. And I realize that this isn't the place to do that, but I'm just telling you because I think you're probably one of the people that maybe knows and maybe can make a difference. And in that case, something's got to be done different because it ain't working.
And I could dovetail.
Our job is to rehabilitate. Our job is to get safe. So the real rehabilitation comes after that. So I hope you're not.
Well, I know what I'm saying is we get there before the assault ever occurs, and the kids need to learn how to deal with it so that you don't have to be called. Now I understand if they're too little that they can't. Huh?
Okay, before we go to fisticuffs here, folks, one of the things that I'm just going to answer and then we're going to move on. But one of the things I think we always have to, it's never either or. It's always both and. And there is a role for law enforcement, there's a role for HHS, there's a role for removals, and there's a role for kids being taught how self-protective actions. You bet, that good touch, bad touch, that everything that you learn in Sunday school, from your parents, from your grandparents, are all things that are going to keep you safer. And so hopefully from the combination of those things, we're going to be able to do it. But it's never either or. Okay, I'm supposed to talk about preparing people to court for testify. Really, you guys could just come up here and teach this. Okay, one of the things that I was thinking about as I do this is that I'm always thinking about how does the therapist think when I call? And I say, I need you to come to court to testify, because that always helps me try to react to them a little bit. The thing that I think most of them are concerned about, and I'm going to be the nice person first, they're worried about the client, and they're worried about the impact that this testimony is going to have on the client. I mean, quite frankly, it was pretty heartbreaking. The other day, we were involved in a termination trial, a termination of parental rights trial, and the mom hadn't showed up, and the mom hadn't showed up. She hadn't showed up for all the other days of testimony, but the one day that the therapist was there to testify, the mom showed up. And I just felt bad for the therapist. I don't know why the mom chose that day to come to court, but she did. And I know that at some point in time, I was asking her questions. She literally turned and faced the client and started talking to her client in court while she was answering my question. She wasn't answering me. She started talking about you. You need to do this. So that they are thinking mostly about how this is going to impact their clients. As a county attorney, that always drives me crazy, because what they tell me on the phone is never the same of what they come to court and say. So anyway, and they're worried about that relationship. Obviously, they spent years, many times, working on that relationship, and now we're asking them to come to court to testify and reveal all sorts of things that may not be very good, for their client. And the other thing I don't know, you guys are a bunch of scaredy cats, I think, of lawyers, but that whole notion of saying the wrong thing, I'm going to say the wrong thing, and it's going to be misinterpreted and blah, blah, blah. One of the things that I try to tell people when I have the 3 minutes that I have to prepare them to testify, because usually what I do is I go, okay, here's my petition. Read that, and you got anything that that would help me prove that? I mean, that's what I call trial prep. But seriously, but the one thing that I try to get them to think about is that if they say something in court and they realize that they didn't say it right or it's being misinterpreted, that they are the person who, and I literally say this, you are responsible for your testimony. I'm not, and the other lawyer isn't. If you're being misinterpreted, you have the duty to tell the judge that you need to correct something. And you know, that's hard to do, but I've even seen kids do it in the course of their testimony and say, wait, you got it all wrong, that isn't what I said, or if I said that, what I meant was, etc. The other, they're very, what's the defense attorney you're going to do me? What's the defense attorney? I go, they're really easy, they're putts. No. Sometimes I'll say, you know, quite frankly, I haven't the slightest idea, because there's sometimes when I can't think of a defense. But you know, I'm at least going to talk to them about what the defense is that I think is there. Or, you know, and most of the time I'll just say, you know, really it's being unprepared that they're going to grill you about. If you don't know, if you have not reviewed your file, you're going to get grilled. And if you don't know your facts, you're going to get grilled. For somebody, I mean, if there's a defense attorney who's out there and is really prepared for this, and you're going to get grilled, so you need to know. Well, then, of course, you know the real question. Okay, well, we'll get to that in a minute. The other thing, I think they're worried about exceeding their expertise. You know, can I really say this? Really? Can I say this? Yeah, you know, and I'm going to say, you're the expert, not me. You're the one who has to decide how far you can go in a particular situation and how much you are willing to say. So anyway, we have some of these, you know, in my 3 minutes that I spend with my witnesses, that's the kind of stuff that we talk about. The other thing that this is, they always want to know how much time it's going to take. What time are we going to start? When are we going to be done? Can I keep my 10 o'clock? If I start at 9, can I tell my 10 o'clock that I'll just be 10 minutes late? Well, hell, I don't know.
Don't lie.
Right, you know.
If you're the therapist and then somebody at the county attorney's office says, you're only going to be there for an hour. And I'm like, I've been here for 5 now. So if you had told me 5, I wouldn't be so angry.
You know, and if
at the end of hour 2, looking at you going, I am now upset.
Yeah, and then there's all the time they spend in the waiting room, whatever. Yeah, I know. Okay, so I tried to say to somebody, obviously, I don't know, you know this, I don't know how much time it's going to take, blah, blah, blah. Okay, so they also want to get paid for their lost income. Have you ever had that, where they come and go, well, you know, if I sit here, I could be earning blah, blah, blah per hour. You know, and I'm sitting there going, this is your client, and you already got paid by the Department of Health and Human Services to deal with this client, but you know, then I'll just say nicely, no, you don't. You just get paid the amount of money that we're willing to pay you, which, by the way, you're not going to get paid for your file review. And most of the therapists want to get paid for file review. And you know, our office, do you guys ask the judge to pay for file review? No way. You know, and then they want to know how they're not going to get grilled, and I'm going to say by doing the file review that I can't pay you for. You know, which isn't very nice, but that's really what happens. And then, of course, they want to get paid. How much, Hazel? Everybody wants to get paid $250 an hour, right? You know, I mean, how many times have we had a case where, you know, no, you're not going to get paid $250 an hour. We're not paying that. What does the court pay for therapists? For just plain old therapist testimony, if you guys ask for, you want an expert. How much?
If it's somebody that's already involved in the case.
Already involved in the case, they get a $20 witness fee?
Yeah.
You guys don't even ask the judges? Oh, I'm going to start doing that.
I wouldn't come for that. I'd quash your subpoena for that.
You're not going to
ask me expert questions.
Hiring an expert separate to examine the case, that's one thing. But
yeah,
if you're
that's what I was
working
going to say.
As a therapist, like you said, then.
Yeah, but you're going to ask this person expert fees.
If you ask me for my opinions, I am going to think you want me there as an expert. If you ask me for recommendations, you're asking me to be an expert.
Well,
and
whatever role you had in the case is what I'm going to be asking you to appear.
I'm surprised that they'll come for $20 witness fee, you guys. Seriously, that's why you always ask me to call them, right? Alicia, could you get this witness here? Because you have to pay $75. Yeah, we usually, our office has taken to paying $75 an hour for a therapist if we're going to use them as an expert witness. And I always tell them, you know, because I'm so, Yeah, I hold back so much. When your rear end hits the chair in the waiting room, that's when it starts going, and when you walk out, that's when your meter is done. I mean, I'm just very blunt. We actually got our fees down a little bit because Douglas County helped us out by telling us we don't pay them any more than that. But you know, if I were an expert and I'm being asked expert questions, I would want an expert witness fee. So maybe you guys should go to the judges and say.
It depends on the court. In my experience, if you're calling somebody that has been working in the case for a year, they're gonna get the subpoena fee. The court is not gonna authorize $100 an hour.
And then it'd be hard to gain a lot of cooperation and having them actually read the file if that's the case. So, yeah, no wonder I always end up calling the witnesses. Okay, and then what we're supposed to do is plan ahead, or if you're like me, you learn how to grovel. And I'm serious, you know, it's like 3 days ahead of time. Oh my God, I forgot I had this job. And I do more groveling, and it is amazing how you can get people to do things if you just grovel nicely. I don't know what men do, because I don't know if groveling is a male kind of thing to do, but it works really well for us girls. So, what? Do men grovel? You're a man. Do you grovel or do you plan ahead? Yeah, see, that's the point. Men it's just not manly to grovel. What?
But he wouldn't call it groveling.
What would you call it, Scott? Begging?
Yeah, let's go with persuading.
Persuading, okay. All right. Anyway, I'm always behind. I don't know about you guys, but they appreciate, obviously, the more notice as possible. Okay, I try to get a convenient time. I try to start them at 9. I try to start them at 1:30. That's the best I can do for them. I always tell them, if we get you on at 9, you'll be on and off. Otherwise, if I put, say, 10:30 and we're in the middle of something, you're not going to get on the witness stand. Okay, so that's easy. Get that agreement on payment issues, or you're going to have one pissed off therapist. And then I try to, I generally try to tell them why they're testifying. Because you did therapy with the kid, thanks. That's, again, good trial prep. Well, that doesn't help very much. Sometimes I'll say, I'm trying to get your letters into evidence, because really that's all I need. You've already written stuff, and I just need to get it into evidence. But there's other times when I'm really trying to pull a whole case together with that therapist testimony, and I'll spend a lot more time talking with them about that. And this is, to me, really, this is sort of the heart of it. The rest of that was just to wake you up. Is why are you calling this therapist as a witness? And so, you can look at all the possible reasons. These are things that I always, do I always know why I'm calling the therapist as a witness when I actually subpoena them? Sometimes I really know, but sometimes after the second or third day of trial, I finally figured out what it is that I need that therapist testimony for, because I now kind of have the issues gelled in my head. But you really ought to know why the heck you're calling him as a witness. The other thing that I've always done is, maybe Nicole has better luck, but I have a hard time getting a therapist to say, for instance, that it is in the child's best interest for termination of parental rights to occur. Have you guys ever had the situation where you've got a therapist who thinks, in her head, there's no way kid should go home, termination should happen, but they will not say the words on the witness stand? What do you do? Or they will, you're a GAL and you're thinking, what? Why not? What do you get them to do? Yeah. Okay, so like what? What do you ask them then? Instead of flogging them over the phone with, you've got to be kidding me, you idiot, how come you can't? Instead you use positive things. So what do you do?
Like what's good for this child? What kind of attachments do they need? What kind of support at home? Just to describe the situation that would be best for the child, and then do they have it with this parent, and then try to...
Yeah, and sometimes the reason they won't say termination is in the best interest of the child is because they don't know enough about the relationship with the parent, right? So you get them to say all the really good things about what this kid needs, what kids need in general, what this kid needs in particular, and why that kid needs it more than anything, especially when you're talking about trauma. And one of the things we didn't go into a lot was, what is the most therapeutic help for a child? So, I hate those cases where you've got the domestic violence situation, dad perpetrates on mom, dad perpetrates on mom, kids get removed, mom never says anything happened, and there's nothing to work on, and you go nowhere in those cases because you don't have a protective parent to try to get back together with a child, and the therapist will testify what, you know, Johnny needs is recognition from his mother that this happened. That's the first step, and we've never gotten past the first step. And you know, you use all the stuff you just learned here to be able to do that.
And we won't answer those questions because we think they're a legal question. So you're asking us to make versus a therapeutic question is why they'll say it's the ultimate question about custody is a legal question, not a clinical question.
And one of our, you know, some of our judges will allow in evidence that says what's in the best interest of the child. You believe termination is the best, and others won't because of that same thing. It's a legal question for the court to decide. Others will say, I'm accepting it as the expert's opinion on this. My legal standards may be different. And so they'll allow it in just as an assistant to the court, you know, and which is right and which is wrong, I don't really know. They'll get it in writing. That's what you know, we ever get, especially doctors, good Lord, doctors, they go all over the place. And they will say things to you on the phone and then they will not say them in court. So I always ask them, could you put that in writing? Let's get that in writing. This is what we already talked about. Okay. So we're back on more purposes. Hold on here.
Just to clarify, I'm not saying that we shouldn't pay the time for the therapist.
Hazel would like to a moment.
Yeah. Not give it to us.
Yeah.
All right. Okay, so this is a trauma-focused class, right? Teaching. So one of the things that you would probably do after going to this is you're going to say, tell me about your training and education in the area of trauma, right? And what have you been taught that children often exhibit? Have they exhibited trauma? Okay, so you go through it. What are the symptoms? What testing have you done? What assessments have you done? Conversations, observations, literature, training experience, all of those things to say that I believe that this child is exhibiting symptoms that are trauma-based. Why would you want to do that? For what, when in court would you want to say, I believe this child is exhibiting symptoms that are trauma-based? Yeah. Okay, to get to the treatment that's appropriate for the child. Most of our judges would do that without having to do all this whole link with a therapist. So it's not likely somebody would have to testify about this, at least in Lancaster County. Maybe in other places you'd need to. When would you use that kind of testimony? This child is exhibiting symptoms that are consistent with trauma. Adjudication on 3A because I've written what at the bottom of my petition? All the risk of harm, right? The above has caused risk of harm. So I would use it to say that this child is exhibiting symptoms of trauma, and then I'd have to put the other people on to show at least what trauma it might be coming from, right? So this child, we need intervention because of this. ICWA is another obvious place where we need this. Continued custody of the child, but the parent is likely to cause serious emotional or physical harm. I mean, you think about therapist testimony in an ICWA case it's usually emotional harm if you've had a trauma-based filing in the first case. Sometimes it's physical because the parent, you know, is using drugs and alcohol and they just physically cannot take care of their child. But we might use a therapist's testimony for that. Best interest, we've already talked about that. There's our risk of harm one. What else? What interventions are necessary for this child, right? So you've got your, I think this kid needs a trauma-informed something. The parent says, no, we're not doing that with my kid. What if you have an OJS kid or a 3B kid? You ever think you'll need a therapist testifying? Probably not with our judges. I do think this is interesting because I had a trial where, like I was saying, where the parent didn't acknowledge the child's trauma. And that literally was the kernel at the very center of the termination of parental rights on the mom. And it was the saddest trial. I've done a lot of sad trials in my life. It was probably the saddest trial I've ever done, and then I had to do it again because mom and dad had another baby after the termination. And so you've just sitting there at that kernel of nobody ever dealt with the children's issue of trauma, never agreed the children had trauma, and how can we ever get there? So yeah, the role of the non-offending, and maybe we can talk a little bit about that in our next, we have to do this 2 more times. Oh, we get to do this 2 more times. And maybe we can talk about that role of the non-offending parent on that. The role of the offending parent on the progress of the child in therapy. I was sitting here thinking about, you know, about visitation and thinking, good grief, at these temporary custody hearings where we are automatically ordering supervised visitation between the offender and the child. I mean, we all just agree to that, right? I mean, guardian ad litem are all going, yeah, you know, it's going to be supervised, so there won't be any more physical abuse. But we've done absolutely no assessment whatsoever about whether that's appropriate for the child. We all just assume, well, fine, he's not going to hit the kid while the kid is there, and the mom's not going to be there, so they're not going to be traumatized by domestic violence during that. I don't even think about the fact that just the presence of that person may be the trigger for the child. So anyway, that may be something that, you know, we end up using a trauma assessment for, and saying that we should not have at this time supervised visitation. We need X, Y, Z first, therapeutic visitation followed by something else in a particular situation. At least I hope we can have those conversations. I would think this would be what you guys would be saying all the time, is if you've got a case where we've got an ongoing therapeutic relationship between a child and a therapist, and we've never done a removal, and now we're talking about the possibility of removal. If I were a guardian ad litem and I'm worried about that, I'd be putting a therapist testimony on there about what the impact of removal of the child from, let's say, the non-offending parent, or the removal of the child from whatever that situation, what that impact might have on that child based on all the information that you've learned about that child. Anybody got any other ideas about what you might use your therapist for? That's everything almost that I could come up with. Well, I guess I have one more. This is the same thing. What does this child need given the trauma? What connections or contact do they need to have with siblings? What does this child need for permanency? What does this child need to stay in contact with their parent? Anybody got any other ideas about what a therapist could be used for as far as testimony, not for treatment? We covered them all? I know it's like 4:35. What time is it? 4:20. Oh, sweet. I mean, you guys are going to get out right on time. Okay, so you know, this is all this stuff. This is fantasy land right here, me, you know. This is what I would like to do. If I were a good lawyer, I would say the following things. These will be the issues, and we are going to have a trial. But the other thing is, do you have any information? Because I do like to talk, but I have always found that with therapists, if I just shut up and say, okay, here's what I'm thinking, but you've been dealing with the child, here's what I'm supposed to prove, and then really say, what can you tell me that will help inform the court's decision? And they'll oftentimes then tell me all the stuff that's not good for my case. Ooh, thank you. You know, I need to know that too, right? They're going to tell me the stuff that they think is helpful, but they'll also tell me the things that they believe or the opinions that they hold that are not helpful to my case. So I try to talk to them. Do you guys have more time than I do? Because I spend most of my time about 2 seconds right before court. Here, I'm putting this on the evidence. Hopefully you can say something good when you get there. But when I do, and I've probably done my best work when I just shut up and ask that open-ended question, what do you know? What can you help me with? What can you testify about?
And I will second that. That's the best question you've ever asked, is what is it that you think the court needs to know about this kid? What is it that you think the court needs to know so that this kid can get what they need? Yeah. It's a lot easier for me to answer that than rapid. It's a lot easier for us to work backwards, kind of process backwards about this is all the stuff I think needs to get to go there, and for you to tell me what I'm going to have to know before then the other way.
Yeah. Jenny, you did the case that you gave me the pictures on, right?
Yeah.
And I think this happened when literally I'm scrambling around. I have an Indian Child Welfare Act case. I have a therapist. I don't know what I'm doing. I don't have enough time. I got to figure out. I didn't know it was Indian Child Welfare Act till, you know, halfway down through it. And I'm going, oh crap, I have to have that active efforts and continued custody is likely to prevent serious, blah, 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 all that stuff. What am I going to do? I have to call the therapist. Okay, Jenny. Hi, Jenny. Jenny, I need you here. Can you come here? Tell me about this kid. And Jenny's smart enough to realize, well, she was married to a lawyer. Smartly, she's no longer married to the lawyer. But she said, would you want me to bring the pictures? Pictures. What pictures would those be? Because I'm really smart. What pictures would those be, Jenny? Well, the pictures of the kid, I believe it was under the table. Mm-hmm. And the person coming in, and is it her mom who's on the floor?
The picture was of a child underneath the table with the mother hiding and the boyfriend with a blood-soaked knife coming at them.
This was the picture that was drawn in therapy. If I hadn't, if we hadn't done anything about, what can I bring, or if Jenny hadn't been smart enough and just said, I have something that you need. I can't remember which way, it actually probably was that way. Because she taught me a lesson to make sure I asked that. I mean, I literally, in that case, when I was in front of the Court of Appeals on appeal, because I did actually get to win, that was fun, I went up to the Court of Appeals and I put it on, the Court of Appeals actually has that little thing, the little, what do they call that? Overhead projector. Okay, so they have an overhead projector, and I started, that's how I started my argument. Because it seems to me that that was the piece of evidence in the case. This is how this child viewed her life. And of course, Jenny was able to then explain how this child had drawn the picture and and obviously this child really was at severe risk of harm if she were to go back to a place like that, where again, there was no acknowledgement on the part of the parent that any abuse had happened at all. So in that case, all 3 children had to testify. That was an awful case. And yeah, so is there anything else you think I should know or ask about? One of the things that obviously, you guys have seen us all do this, where you nail a therapist, which is not what you want to do, but if you're on cross, maybe you want to nail the therapist. They don't know the diagnoses, so I would say, please make sure you know the diagnostic criteria for this, or bring it with you. What were the testing results? What were the tests for? Are the tests validated? How so? Treatment plan. They should have a treatment plan. I should be able to look at the treatment plan. We should know whether they've made progress on the treatment plan. And hopefully, for heaven's sakes, the treatment plan has something to do with the adjudication in the case, right? So that's what we are always hoping for, because sometimes our treatment plans have nothing to do with our case. There's the artwork. That was my example. I've never seen a trauma narrative. I think that would be interesting to ask a therapist to bring and explain what a trauma narrative is. And perhaps you would tell us what it looks like.
Well, it's a story, so that a lot of times kids will write and illustrate the story of their trauma.
You're supposed to come up to that microphone.
Yeah, I'd be really hesitant as a therapist when a kid is able to write to bring the actual trauma narrative unless I had probably their permission. Or if they're at that stage where they're working with the parent. I mean, the idea is through the retelling, and once you teach the child the coping skills, they're able to then write out and read and discuss the trauma narrative eventually with a parent present who's also able to respond appropriately, accept that trauma, and then kind of work through that. But they write out their story in as much detail as possible. So it includes descriptions of sights and sounds and smells, things that they were going on, how they were feeling, thoughts that they were having. So we write it in layers. The first description is just the facts of what happened. The second one is, these are the things that I saw, the more kind of the visceral, they were seeing and smelling and hearing. The next layer would then be the thoughts and feelings, and usually that's the saddest part, because they say things like, if Sandra was old enough to do a trauma narrative, it would say things like, it's my fault because I left the door open. It really gives us the ability to then go back in as a therapist and work with the parent and have Sandra's mom say to her, it wasn't your fault. I realize when I read this that you think you opened the door and that's what happened, but he was gonna you know, this was going to happen if I didn't leave him anyway, and now mommy's done X, Y, and Z to make sure you and I are safe. So it gives a parent and a therapist the ability to correct distortions, but it's intensely personal. I mean,
yeah, but the point is, if you got to the point where a child had done a trauma narrative and the parent had not made enough progress to be able to share the trauma narrative with the parent because it wasn't safe enough to do so, you know, as a guardian ad litem, that would be something that would be very helpful if you were talking about, you know, what are the next steps for this child? What are the, you know, what's permanency look like for this child who is unable to share that and needs to share that? So I would hope that we would be able to, you know, have some testimony about that, maybe not about exactly what the kid put in there, but that. And obviously we need treatment and discharge recommendations from them. You know, I don't know how you get them to review the file. Could you, chocolate? Chocolate sometimes works. It works with me, right, Gail? Oh, that's twice today I've called you out. Validity of your assessment instruments, they need to know that how they were valid. Seriously, sometimes I think we do a terrible job on cross-examination in court with therapists. We just let them say whatever they want to say, and we don't ever question what they say very much. And you know, there's a lot that they shouldn't be saying. And we appreciate it
so very much.
Yeah, yeah. But really, you know, we hardly ever ask them to tell us what the literature says about this particular topic or what literature they've read or anything else. You know, you could do a pretty good destruction of a therapist's testimony if you wanted to take one to do that. Has anybody ever used the learned treatise exception to the hearsay rule? Look it up. It's the coolest thing ever. You know when I used it, the only time I've ever used it? A dog bite case in county court. Well, we were going to destroy the dog, and I lost anyway in the Supreme Court. But the judge allowed me, because you know they put somebody up there and said the dog's fine, the dog doesn't need to be destroyed. I mean, this is my life, right? Okay, this is, yeah. And anyway, I used the learned, and Judge Yardley, forever after, whenever she sees me, she goes, "There's the learned treatise exception to the hearsay rule coming." But anyway, it's a good thing to do because you can take things from the, if they say, yes, this is a treatise, you can read to them stuff that's in direct opposition to what they're testifying to, and it is very destructive. So, you know, this is that only the county attorneys in the room heard that and the guardian ad litems. If you are a parent's attorney, pay no attention to what I just said. Okay. Oh, hold on here.
And that's how you get them to review the file, is tell them that
Yeah, tell them
story.
that they need to do that. Right, exactly. Why is this not working? Okay.
Did we run out of batteries?
Is it? Is that what happens? That is sweet. Are we done? Okay. Hey, Jenny, I think we're done. Because they told me that that's how it is.
Did we run out of batteries, maybe?
I don't know. It doesn't matter. They're done. If their brains are dead, it is. Anyway, yes, have them review their collateral information. That was fun the other day, another trial, another therapist who hadn't reviewed his collateral information. Okay. You don't have any questions. We know that. But if you have a question you want to come up here, because nobody wants to sit and listen to your question at this time of day.
If you're a CASA worker, I have some guides for birth parents with trauma histories that are specific to CASA up here.
Oh, she left.
So you got one, though.
You got one, okay.